Welcome back to part 2 of our discussion on the role of polyenylphosphatidylcholine, PPC, in the prevention and treatment of cardiovascular disease and within the broader field of integrative medicine. As you know, my name is James Roberts. I'm board certified and university trained in internal medicine and invasive cardiology, and I'm an advanced fellow in anti-aging and regenerative medicine. I describe myself as a specialist in the field of integrative cardiology. My focus is thus on cardiovascular disease, but in a sense, I've become a doctor of human pathophysiology. If a drug or nutritional substance that I use in the treatment of cardiovascular disease helps in disease states involving other organ systems, I don't hesitate to recommend their use to you as you address your non-cardiovascular health challenges. Likewise, if drugs traditionally used in the treatment of oxidative and inflammatory stress involving other organ systems can help us deal with atherosclerosis and heart failure, I'm all in. I've become a practitioner of integrative cardiology and integrative medicine. I like this approach, I teach this approach to other doctors, and I want you to know everything that I know. Part 1 focused on the use of PPC and atherosclerosis, how we can use PPC to lower cholesterol, and of much greater importance, how we can use PPC to remove cholesterol from the artery wall and restore normal blood flow. We touched on the use of PPC to improve cell membrane function and as a means of lowering oxidative and inflammatory stress. Part 2 will explore this physiology further, starting with a discussion of oxidative and inflammatory stress and how PPC will attenuate both. Lots of biochemistry, lots of animal models, and a lot of clinical trials. It's not critical that you understand all the details. That's for me to understand. But please do your best to follow along, as I'd like you to leave with a deeper understanding of human health and how PPC can help you to optimize your individual health. Part 2 will begin with a review of oxidative and inflammatory stress and how we can use PPC to attenuate both of these pathophysiologies. We'll discuss the use of PPC to improve the function of the cell membrane of every cell in our body. PPC is of value in dealing with inflammatory conditions involving the upper and lower gastrointestinal systems. We'll talk about the use of PPC to protect our cells, to protect our organs, the benefits of PPC in reperfusion injury. There are studies that suggest that PPC will be of value in neurologic health. We'll introduce you to this concept that I call cardio-hepatology, the use of PPC to address essentially every disease state that affects the liver. PPC will decrease our risk of cancer because anything that lowers oxidative and inflammatory stress will lower our risk of cancer. TMAO is an at least theoretical downside of PPC supplementation. We'll discuss the TMAO concept and how we can attenuate it. We'll talk about the use of PPC as an anti-aging supplement. I will summarize and then I will list references for both part 1 and part 2. If we are to prevent and stabilize atherosclerotic vascular disease, it is key that we identify and resolve the abnormalities in vascular biochemistry and cell biology that drive this disease forward. Key in the initiation and progression of atherosclerosis are oxidative and inflammatory stress. Oxidative and inflammatory stress will lead to hyperlipidemia. Hyperlipidemia will lead to oxidative and inflammatory stress. All three must be present: hyperlipidemia, oxidative stress, and inflammation to initiate and drive forward atherosclerotic vascular disease. The terminal event, plaque rupture, is essentially an oxidative and inflammatory bonfire. Plaque rupture occurs at a shoulder region of the plaque when matrix metalloproteinases generated by macrophages stimulated by interferon gamma released by activated T helper cells degrade the fibrous plaque, allowing the atheroma, which you now understand to be cholesterol oleate, into the flow area, producing an unstable plaque, a clot, and a coronary event. This is an oxidative inflammatory bonfire when the generation of reactive oxygen species, free radicals, is not balanced by the presence of neutralizing antioxidants within the vascular wall. Atherosclerotic vascular disease is a maladaptive response of the immune system to what it perceives as infection of the artery wall with oxidized lipids. Whether you believe in creation or Darwinian evolution, we have been evolving on the planet over the past 4 million years. The natural predator of man and the leading cause of death in the history of mankind is infection. When primitive man experienced oxidative stress, it was due to another infection. Thus, when we experience oxidative stress, it is appropriate from the point of view of evolution to initiate an inflammatory response. Modern man is not dying of infection. We have sanitation, we have antibiotics, and if you're working with a practitioner trained in integrative medicine, available to you are other antimicrobial methodologies such as ultraviolet blood irradiation, intravenous vitamin C, intravenous silver protein, digital homeopathy, or nutritional supplements designed to appropriately upregulate the immune response. Thus, modern man rarely, if ever, dies of infection. Yet modern man is experiencing chronic oxidative stress, not due to infection, but due to environmental exposure and lifestyle factors. We are being exposed to heavy metals, organic pollutants, and inhaled hydrocarbon toxins. They generate free radical oxidative stress. Our diet, high sugar, high saturated fat. We have leaky gut, thus we have chronic oxidative stress. We may bear chronic infections such as gingivitis. Allergy and chronic emotional stress will also lead to oxidative stress. Modern man is experiencing chronic oxidative stress, and Mother Nature can't differentiate this inappropriate oxidative stress due to diet, lifestyle factors, and toxin exposure from oxidative stress due to infection. Thus, we're chronically on a war footing. We're experiencing oxidative stress, and this is leading to an inappropriate and maladaptive inflammatory response. Oxidative stress will always give rise to an inflammatory response. Thus, if we're experiencing chronic oxidative stress, we're experiencing chronic inflammatory stress. So, how does oxidative stress give rise to inflammatory stress? Nuclear factor kappa beta is our primary inflammation amplification pathway. Our cell membranes, particularly the cell membranes of cells involved in the immune response, bear receptors for specific threat signaling molecules, such as inflammatory cytokines, tumor necrosis alpha, angiotensin II. Lipopolysaccharide is the material that makes up the cell wall of gram-negative bacteria, or free fatty acids. When these molecules signaling infectious threat bind their receptors, enzymes are activated that lead to the degradation of the inhibitor of nuclear factor kappa beta called ICBA. So if ICBA is degraded, nuclear factor kappa beta is no longer sequestered in the cell fluid, the cytoplasm. It can translocate into the nucleus and begin to read the DNA to generate pro-inflammatory mediators and cytokines. Well, if we're experiencing oxidative stress, if we have hydrogen peroxide in the cell, hydrogen peroxide alone will cause nuclear factor kappa beta to translocate to the nucleus, so we generate inflammatory mediators and cytokines. Why is this occurring? We don't need infection to translocate nuclear factor kappa beta to the nucleus. All we need is oxidative stress, because as far as Mother Nature is concerned, if we're experiencing oxidative stress, it's due to an infection. So oxidative stress, nuclear factor kappa beta translocation, we mount an inappropriate immune response. So oxidative stress will give rise to inflammatory stress. Oxidative stress and inflammatory stress also leads to hyperlipidemia. Why does this occur? And why would this be considered appropriate from the point of view of Mother Nature and evolution? Well, when we are experiencing inflammation, oxidative stress, that increases the generation of cholesterol. We upregulate HMG reductase, that is the rate-limiting enzyme in cholesterol generation. Why do we need that? Well, we need cholesterol to make the cell membranes of all these white cells that we are going to recruit to kill the infection. And we don't need just white cells, we need bullets. We need inflammatory mediators and cytokines. So downstream to HMG reductase, we also activate an enzyme called NADPH oxidase that leads to oxidative stress, which leads to inflammatory stress to help us fight the infection. So this leads us to what I'm going to call Roberts's rules of intimal disorder. Oxidative stress recapitulates our response to infection. Oxidative stress will lead to inflammatory stress, hyperlipidemia, hyperglycemia. When we're inflamed, we become insulin insensitive. Why? Because the white cells need sugar to fight the bacteria. We're going to activate the immune system. We want to activate our endothelial cells to allow the white cells to translocate from the vascular flow area into the tissues to kill the microbes. Dysfunction at any foci will affect all the foci. So if you have a blood sugar of 600, that's going to lead to oxidative stress. That will lead to hyperlipidemia, inflammation, immune dysregulation, endothelial dysfunction, and vice versa. Correction at any one foci will favorably affect the others. So if you have high blood sugar and endothelial dysfunction, I know you have oxidative stress. If I lower oxidative stress, I know that your sugar is going to fall, that your endothelial dysfunction will resolve. So dysfunction at any one foci will negatively affect all the others. Correction at one foci will favorably affect others. Thus, we want to lower oxidative stress, we want to lower inflammatory stress, and as you will see, we can do so with PPC. Oxidative stress involves an imbalance. You have too many free radicals, too many reactive oxygen species that is not being counterbalanced by appropriate antioxidant defense support. What is a free radical? Jerry Rubin out on bail, Marx, Lenin, unrepentant terrorists Bill Ayers, Saul Alinsky, Che Guevara, or other ne'er-do-wells and blaggards that inhabit the seamy underbelly of American society. No, that's not what I'm talking about. A free radical is an atom with one as opposed to two electrons in its outer shell. It is unstable and reactive, so what it's going to do, it's going to snatch an electron from the next atom, quenching its thirst for electrons, but creating a new radical, which will snatch an electron from the next atom, quenching its thirst, but creating a new free radical. So there's going to be a oxidative cascade. One by one, all the atoms in the cell will be oxidized. The molecules will be oxidized, the organelle will be damaged, the cell will be damaged, and it will die. We've talked about this with respect to causes of LDL oxidation within the vascular wall. This pathophysiology affects every cell in our body adversely. What are the endogenous sources of oxidative stress? Superoxide is the primary free radical, and we make a small amount of superoxide as a byproduct of normal physiology. It's involved in cell signaling maintenance, but excessive superoxide leads to oxidative stress, leading to cardiovascular disease and disease in general. We generate energy by burning sugar and fat in the presence of oxygen. We call that oxidative phosphorylation. 2% of the oxygen that we inhale is incompletely reduced to water, and we generate superoxide. NADPH oxidase is activated when we want to fight infection. Unfortunately, it's activated when we upregulate cholesterol production, causing oxidative stress. Angiotensin converting enzymes, xanthine oxidase, nitric oxide synthase, when it's dysfunctional, leads to excessive superoxide generation. When we are detoxifying toxins, organic pollutants, and metals, we will generate oxidative stress. When we have a real infection, we're going to generate free radicals to help deal with the infection, but those free radicals will also damage our tissues. Other enzyme systems, some of us on a genetic basis, are good at generating superoxide, and that was to our advantage when we were dealing with infection, but it works against us as primitive man when we're experiencing oxidative stress on the basis of toxicity, and we're oxidizing our LDL, and this leads to atherosclerosis. There'll be a cascade of free radicals. We make superoxide. We need to neutralize it with superoxide dismutase. We convert it to hydrogen peroxide. We use catalase and glutathione peroxidase to reduce it to water. If not, we will make hydroxyl, which is 1,000 times more damaging than superoxide, peroxynitrate, which leads to endothelial dysfunction, hydrogen peroxide, hypochlorous acid, which is like bleach. We want to bleach the bacteria. We do not want to bleach our arterial walls. So we have this imbalance. We have a cascade of oxidative radicals, and we're experiencing, as modern man, an overwhelming excess of free radicals. Now, we're doing genomic testing, and many of us are downregulated in our antioxidant defenses. Now, if you were good at neutralizing superoxide with superoxide dismutase, that worked against you when you were dealing with chronic infection. So many of us harbor downregulations in superoxide dismutase, catalase, peroxidase, glutathione peroxidase, and thus we are more susceptible to oxidative mediated illness. So we can now look at our weak links, and there's ways we can neutralize them. We can create nutritional workarounds. Non-intrinsic sources of superoxide. Diabetes leads to intensive oxidative stress. Belly fat leads to inflammatory stress that leads to oxidative stress. Smoking, airborne pollutants, heavy metals. Now, we generate superoxide, and we have a means of neutralizing the superoxide with superoxide dismutase and catalase and glutathione peroxidase. But any superoxide or peroxide that is not neutralized in the presence of heavy metals will be converted to hydroxyl. Hydroxyl is 1,000 times more damaging than is superoxide. So if we have heavy metals on board and we're experiencing oxidative stress, there's a synergy working against us. Thus, we're experiencing severe oxidative stress on the basis of heavy metals. Organic pollutants is something we haven't been talking about, but these fat-soluble organic pollutants, this is 2,3,7,8 tetrachlorodibenzodioxin, which is the contaminated agent orange. These materials, once they're in our body, they never leave. And as we try to detoxify them, we generate oxidative stress. These toxins are fat soluble. They travel in our LDLs, and they enter the artery wall and bind a structure within the artery wall called the aryl hydrocarbon receptor, and we're generating free radicals in the plaque so we can oxidize our LDL and drive forward atherosclerosis. So we have intrinsic sources of superoxide. Some of us on a genetic basis aren't very good at dealing with superoxide, and we're all loading up with these pathologic sources of oxidative stress. Thus, we have an imbalance. Not enough antioxidants, too many free radicals. So we're experiencing an overwhelming oxidative assault. So how do we address this? First of all, we need to measure oxidative stress. And as a routine lab test, I will look at markers of oxidative stress. Glutathione is the middle linebacker of our antioxidant detox systems. If it's low, that means you're toxic or you're experiencing too many free radicals. Lipid peroxides is similar to oxidized LDL. It means that you do not have enough fat-soluble antioxidants. The free radicals are oxidizing your cell membranes and your LDL. 8-hydroxydeoxyguanosine is a marker of oxidative DNA damage. It means you need more water-soluble antioxidants. So I will evaluate your oxidative stress profile and take corrective action, either giving you antioxidants, giving you supplements called NRF2 translocators to cause you to generate more of your own intrinsic antioxidant detox molecules. Then we will repeat the study. This was a patient with severe oxidative stress, refractory angina, recurrent coronary disease, diabetes, autoimmunity. We've been working together for a few years, dealing with the source of oxidative stress. His oxidative stress panel is improving, and clinically he's improving. And I know that every chronic disease with which you present is underlied by oxidative inflammatory stress. So rather than treat your individual diseases, I'm going to focus on treating and resolving oxidative inflammatory stress with the knowledge that if we are successful here, we will attenuate all of your health challenges. So we're going to take an integrative approach to oxidative stress. We will give you antioxidants as required to neutralize the free radical storm that you're experiencing. NRF2 translocators are supplements that look like poisons. They're not poisons, but the body responds by making more of your own antioxidant detox enzymes. All the drugs that we use in conventional allopathic cardiology that improve your outcome, that lower your risk of recurrent heart attack, stroke, or heart failure, work, at least in part, by attenuating oxidative stress. And we've talked about these drugs in our various presentations. And of course, if we want to prevent this disease and keep it from recurring, we must remove the acquired sources of non-physiologic oxidative stress. We need to get rid of our belly fat. We need to deal with sleep apnea, deal with toxins, deal with leaky gut. And if we have chronic infection, we need to address this. Now, the question comes up, will PPC attenuate oxidative stress? Absolutely it will. But how does PPC attenuate oxidative stress? Linoleic acid, an unsaturated fatty acid, resists chain reaction lipid peroxidation. Typically, an unsaturated fatty acid, when it is hit with a free radical, becomes itself a lipid radical and propagates the oxidative chain reaction. For whatever reason, linoleic acid will not become a lipid radical. It simply absorbs a free radical hit. Thus, linoleic acid within phosphatidylcholine serves as an antioxidant. It can absorb a free radical hit, but it will not become a free radical itself. Phosphatidylcholine will also blunt nuclear factor kappa beta translocation. Two of the three enzymes that, when activated, lead to nuclear factor kappa beta are inhibited partially by phosphatidylcholine. Phosphatidylcholine will not prevent an appropriate inflammatory response in response to legitimate infection, but it will blunt a maladaptive inflammatory response. If we block inflammation, we will block secondary oxidative stress. While oxidative stress leads to inflammatory stress will lead to oxidative stress. If phosphatidylcholine blunts nuclear factor kappa beta translocation, there will be a secondary decrease in inappropriate oxidative stress. The stronger our cell membrane, the better able is the cell to resist free radical damage. The more phosphatidylcholine we have in our cell membranes, the greater the resilience. The cell can handle these free radical hits with less likelihood of damage. The signal for our cells to commit suicide, this is called apoptosis, relates to the leakage out of the mitochondria of specific enzymes. If the mitochondrial cell membrane is enriched in phosphatidylcholine, it is stronger, it is more resilient, it will be not damaged by free radicals, and thus it won't leak. The cell is less likely to commit suicide, apoptosis, in response to oxidative stress. So via these four mechanisms, PPC greatly attenuates oxidative stress. Let's further examine the means through which PPC provides antioxidant protection. We're going to take liver cells and tissue culture. These are immortalized rat liver cancer cells. And we're going to first incubate them with arachidonic acid. Arachidonic acid is a pro-inflammatory, pro-oxidant, polyunsaturated fatty acid that we obtain from meat and dairy that is converted into pro-inflammatory prostaglandins and leukotrienes of the 2 series. One of the reasons we say to avoid overexposure to meat and dairy is because it's rich in arachidonic acid. We know that arachidonic acid leads to cellular, oxidative, and inflammatory stress. So they incubated some of the cells with arachidonic acid, a pro-inflammatory, pro-oxidant, omega-6 polyunsaturated fatty acid. Other cells were incubated with lipostibial, that's phosphatidylcholine enriched in linoleic acid. In lipostibial, 80% of the fatty acids are linoleic. Another group of cells were incubated with dialinolenyl phosphatidylcholine. That's phosphatidylcholine, which is 100% linoleic acid. That's not available for clinical use. It's available for research purposes. Some of the cells were incubated with phosphatidylcholines containing saturated fatty acids, such as palmitic acid or stearic acid. This would be similar to the phosphatidylcholine, the lecithin that we would get from meat and dairy. And then they incubated the cells with arachidonic acid, which is going to cause oxidative inflammatory stress, and the above phosphatidylcholine mixtures. And then the question is, will these phosphatidylcholine preparations with different associated fatty acids within their side chains increase or decrease oxidative stress brought on by arachidonic acid? LDH is an intracellular enzyme that will be leaked from the cell when the cell membrane is damaged on the basis of oxidative stress. The cells incubated with arachidonic acid experience oxidative stress, and we see a leakage of LDH outside of the cell. And we see cellular death. The cell count falls in response to incubation with arachidonic acid. Oxidative stress, cell membrane leakage, LDH is released, the cells are dying. If you incubate the cells with phosphatidylcholine, irrespective of their fatty acid composition, there's no cell damage, there's no oxidative stress, there's no inhibition of the cell count, there's no release of LDH. Now, if you incubate the cells with arachidonic acid and phosphatidylcholines containing saturated fatty acids, there's no protection. Cell count falls, LDH rises. Conversely, if you incubate the cells with arachidonic acid and phosphatidylcholine rich in linoleic acid, you see that there's protection against oxidative stress, fewer cells die, there's less release of LDH. So phosphatidylcholine with saturated fatty acids does not have an antioxidant effect. Phosphatidylcholine enriched in linoleic acid does have a protective antioxidant effect. 4-hydroxyenol is a marker of oxidative stress. It is akin to malondialdehyde, lipid peroxides, or oxidized LDL. You can see that arachidonic acid is leading to intensive oxidative stress. PPC itself does not cause oxidative stress. Phosphatidylcholine with 100% linoleic acid does not cause oxidative stress. However, these two phosphatidylcholine species enriched in linoleic acid will neutralize the oxidative stress generated by arachidonic acid. Thus, you see lower levels of 4-hydroxyenol. F2 isoprostanes is another marker of oxidative stress. It will rise with arachidonic acid. The phosphatidylcholine species are not toxic to the cells. They don't cause oxidative stress, yet they will attenuate oxidative stress on the basis of arachidonic acid. So you have lower elaboration of 4-hydroxyenol and the F2 isoprostanes. Let's look at PPC and alcohol-induced oxidative stress. Alcohol causes a great deal of oxidative stress, and that is the means through which it causes liver disease and disease affecting our other organ systems. We're going to take genetically normal Sprague-Dawley male rats and assign them to one of 4 experimental groups. Group 1 receives a controlled diet, 36% of their calories from carbohydrate. Another group gets the controlled diet plus PPC. Third group gets alcohol as 36% of their calories, so we're going to make these rats into beer drinkers. The fourth group becomes alcoholic with 36% of their calories from alcohol, and they're treated concomitantly with PPC. Euthanize all the rats at 8 weeks and evaluate liver biochemistry. Relative liver weight. PPC does not cause liver enlargement, alcohol does. This is called hepatomegaly. If you drink too much alcohol, you're going to have liver damage, your liver will enlarge. With PPC, there's a slight attenuation in hepatomegaly. Liver phospholipid content. PPC does not have a significant effect on liver phospholipid content, but alcohol does. Alcohol is going to lead to methyl cycle dysfunction. Proper function of the methyl cycle is needed to generate phosphatidylcholine. Alcohol and other pro-oxidants will deplete phospholipids. So alcohol leads to a reduction in liver phospholipid. Of course, if you treat the animals with PPC, you will neutralize that, and the depletion in liver phospholipid on the basis of alcoholic oxidative inflammatory stress is attenuated. 4-hydroxyenol is a marker of oxidative stress. If you give normal animals PPC, you're lowering oxidative stress, so you see a drop in 4-hydroxyenol. If you feed them alcohol, you see oxidative stress, and PPC will attenuate the oxidative stress due to the high alcohol diet. Glutathione is the middle linebacker of our antioxidant detox system. It's generated by the methyl cycle, and if we supplement with PPC, we lower oxidative stress, we stimulate the methyl cycle, we make more glutathione, that's a good thing. Alcohol will deplete glutathione, and of course PPC will neutralize the depletion in glutathione and other antioxidants due to alcoholic oxidative inflammatory stress. So we can use PPC to resolve oxidative stress. If we can resolve oxidative stress, we can at least in part neutralize all the other phenomenon that lead to atherosclerosis and its complications. I was giving a talk at a meeting on immune dysregulation. Afterwards, this lab guy came up to me and he said, "Would you help us? We're interested in generating a measurement of oxidized LDL." And they wanted some serum samples, and they would use their new method and compare it to the gold standard from Sweden. And so I sent him 27 serum samples of my patients, and a few had low levels of oxidative stress, others had moderate to high levels. Of great interest is individual number 27, who happened to be me, a trim marathon runner. And when I saw that I had moderate levels of oxidative stress, that was a sign to alter my lifestyle, because if I'm experiencing oxidative stress, it's my own fault. So since then, I've changed my diet. I've increased my program of antioxidant nutritional supplementation, and I'm taking 2,700 milligrams of PPC every day because I don't like this concept that my lipids are being oxidized. Let's take now an integrative approach to what I'm going to call LDL deoxidation. NS is a 51-year-old non-hypertensive, non-diabetic male with a mild elevation C-reactive protein 2.5. He is hyperlipidemic, probably on a genetic basis. His LDL was 198, and he had a high level of oxidized LDL. The upper limit of normal is 60, and he was 79. He has a high protein little a. We have another presentation on LPA. This is a genomic cause of atherosclerosis, and high LPA and high LDL synergize to produce atherosclerosis. He had a family history of premature coronary disease, probably on the basis of genomic hyperlipidemia and high LPA. So in October of 2012, he had a calcium score of 3. That's not high, but because he's a youngster, that was at the 50th percentile for age. In April of 17, he developed angina. A heart cath was done. He had an 80% narrowing in the left anterior descending, and a drug-eluting stent was placed. There was an 80% narrowing in the distal LAD, and it wasn't supplying much heart muscle. You leave those intact. He had a 70% narrowing in the circumflex marginal, probably not flow restrictive. You leave that intact, and a mild narrowing in the right coronary artery. He comes back in just 5 months with more pain. The stent's okay, there's no change in the distal LAD, but the right coronary artery in just 5 months had gone from 40% to 80%. Thus, there was intensive oxidative inflammatory stress in that lesion, and it expanded rapidly. So that narrowing was stented, and because he was having pain, the marginal was also stented. Well, the stents were placed, he felt okay for a while, he came back with angina. So at this point, I'm getting involved now. His integrative practitioner had him contact me, and we discussed his situation over the phone, and I recommended ECP because ECP works well in recurrent coronary disease. Sometimes after a stent, you will have impaired endothelial function, and you have angina, even though the stent's open, and ECP works well for that. So we arranged for him to undergo ECP near home in Wisconsin, and we worked on his integrative treatment program to cover all the bases. Then he did ECP and he got better, but he was still having some angina, and he came to Toledo in the summer of 2018, and we treated him with 6 IV PPC treatments, and then he went home taking PPC with EDTA, the Detox Max or the Lipophosphatase EDTA, 3 teaspoons 2 days a week, and then 5 days a week he was taking 2,700 milligrams of standard PPC. When NS first presented in the summer of 2017, his LDL was elevated at 198, and his oxidized LDL was elevated at 79, and his HDL was lower than desirable at 51. So we're all trying to help NS improve his lipid panel. He's working with an interventional cardiologist in Wisconsin, with his integrative doctor in Wisconsin, and then with me. And unfortunately, NS was exquisitely sensitive to statins. He would take a statin, he'd have muscle pain and cognitive decline. NS could only tolerate, and just barely, 5 milligrams of rosuvastatin a day. And so we added in bergamot, 1,000 milligrams a day. Bergamot, like red cheese rice extract, delta-tocotrienol, and amla, is a nutraceutical HMG-CoA reductase inhibitor. These agents, just like the statin drugs, block the generation of cholesterol, and they also block the generation of downstream inflammatory and oxidative mediators. So at this point, on as much drug and nutraceutical therapy as NS could tolerate, his LDL was better at 103 and his oxidized LDL was down to 55. But we really wanted to get NS's LDL down to 70 given his young age and the rapid progression of his coronary disease. So we added in Repatha. That is a PCSK9 inhibitor that will synergize with statins, be they pharmaceutical or nutraceutical, to lower LDL. And we had treated him with intravenous PPC. He's now on oral PPC. And as you know, PPC will lower cholesterol. And as you now know, PPC will attenuate oxidative stress. So now we've got his LDL down to 20. His oxidized LDL is down to 16, and his HDL is up to 62. Now that LDL of 20 is probably too low. It's great for his arteries. It's probably not great for his brain and other organ systems. So of course, what we did is we lightened up on the rosuvastatin and kept him on the PCSK9 inhibitor, the Repatha. We're keeping him on the PPC. We want to keep his LDL low, and of greater importance, we want to stimulate his HDL to pull cholesterol out of the artery wall, and we want to block oxidation of LDL, and we've achieved that utilizing drugs, utilizing nutraceuticals, utilizing PPC. This is an integrative approach to LDL deoxidation. Now let's look at the GI tract a little bit. PPC and nuclear factor kappa beta translocation within the gastrointestinal system. Here we're going to take CACO2 cells. This is an immortal human intestinal cell line that is used in research of inflammatory diseases of the GI tract. We're going to incubate these cells with tumor necrosis factor alpha, which is an inflammatory cytokine, with or without phosphatidylcholines at varying concentrations. We're going to evaluate the activity of extracellular related kinase 1,2, mitogen active protein kinase P38. These are serine kinases that mediate reception of threat with nuclear factor kappa beta translocation, which will lead to the generation of inflammatory cytokines. So we have these inflammatory signals such as TNF alpha activating the signaling kinases, leading to translocation of nuclear factor kappa beta into the nucleus to generate inflammatory cytokines. So these serine kinases are ERK1,2, which is extracellular related kinase 1,2, P38 mitogen active protein kinase, C-Jun N-terminal kinase. Nobody really needs to remember all these, but when they are activated, they lead to nuclear factor kappa beta translocation, leading to an elaboration of pro-inflammatory cytokines and oxidative mediators. So when nuclear factor kappa beta is activated, it goes to the nucleus, binds to the promoter site, and leads to the transcription of genes for inflammatory mediators. Is nuclear factor kappa beta important in cardiovascular health? Absolutely. Let's look at nuclear factor kappa beta expression in stable versus unstable coronary disease. 102 consecutive patients undergoing angiography. 19 have unstable angina. They have an active plaque where there is uncontrolled oxidative inflammatory stress. 83 do not have unstable angina. 53 have stable coronary disease, 8 have valve disease, other problems, and 29 non-cardiovascular control subjects without infection or inflammation assessed for activation of the nuclear factor kappa beta pathway. Individuals with unstable angina have heightened expression of nuclear factor kappa beta. That's why their angina is unstable. Oxidative inflammatory stress in the circulation, in the vessel wall. They have an unstable plaque, thus unstable symptoms. So we know that nuclear factor kappa beta activation is a sign of plaque activation, and of course it's going to be a sign of oxidative inflammatory stress in any cell of the body. So let's see what happens when these cells are incubated with tumor necrosis factor alpha, with or without phosphatidylcholine at various concentrations. So if we incubate these cells with the inflammatory cytokine tumor necrosis factor alpha, we see high levels of nuclear factor kappa beta translocation, as you would expect. If you co-incubate the cells with tumor necrosis factor alpha and phosphatidylcholine at increasing concentrations, you can see an attenuation in nuclear factor kappa beta translocation. So this inflammatory cytokine is no longer activating nuclear factor kappa beta, leading to amplification of the threat response. Here in red is nuclear factor kappa beta. When the cells are at rest, the nuclear factor kappa beta is sequestered in the cytoplasm, the cell fluid surrounding the nucleus in the center of the cell. If we incubate the cells with TNF alpha, what you see is the nuclear factor kappa beta translocates to the nucleus, so the nucleus is now red, and and at this point it's generating a lot of inflammatory mediators. Here we have the cells at rest, and the red is the nuclear factor kappa beta sequestered in the cytoplasm. If you incubate the cells with the inflammatory cytokine, it all goes to the nucleus. If you co-incubate with phosphatidylcholine, more of the nuclear factor kappa beta is retained in the cell fluid. It's not translocating to the nucleus, so inflammation is attenuated. IP-10 and interleukin-8 are inflammatory cytokines that are generated when nuclear factor kappa beta translocates to the nucleus. You can see this is blunted if you co-incubate the cells with PPC along with the inflammatory cytokine TNF alpha. So we've demonstrated that phosphatidylcholine will blunt nuclear factor kappa beta translocation and blunt the elaboration of inflammatory mediators, inflammatory cytokines, when the cell is exposed to threat, here as exposure to tumor necrosis factor alpha, an inflammatory cytokine. So how does phosphatidylcholine work? Well, when the cell is exposed to a threat, the next step is activation of 3 serine kinases that will then liberate nuclear factor kappa beta from its sequestering molecule called ICPA, allowing it to translocate to the nucleus. Now, when these serine kinases are activated, they are phosphorylated, and tumor necrosis factor alpha will phosphorylate P38 mitogen active protein kinase and extracellular related kinase 1,2. That phosphorylation is blunted with phosphatidylcholine. So in a nonspecific fashion, the response of the cell to a threatening signal is blunted, so you'll make fewer inflammatory mediators. You won't knock it out completely. You'll still be able to respond to legitimate infection, but when you're being exposed to pseudo-infection, inappropriate inflammation, that inflammatory signal, which is maladaptive, will not be amplified as much if you take phosphatidylcholine. How does it work? Well, if our cell membranes are enriched in phosphatidylcholine, they're more fluid and elastic, and these threat receptors are kind of crowded into a region called the lipid raft, and that downregulates their sensitivity. So if you have youthful levels of phosphatidylcholine in your cells, you will have a blunted inflammatory response when it is pathological. Kids are not as sick as adults. Kids have lots of phosphatidylcholine in their cell membrane. They're less likely to experience inappropriate inflammation. So if we supplement with phosphatidylcholine, we have more youthful cell membranes, and this will downregulate the inflammatory response in our best interest. Well, how will this help us clinically? Let's look at PPC, polyenylphosphatidylcholine, versus red yeast rice extract and cytokine suppression in non-alcoholic fatty liver disease. So we have 82 subjects with high cholesterol and non-alcoholic fatty liver disease. That is, you take in too much carbohydrate, you fill your liver with fat, and you have liver inflammation. And this is a common phenomenon in middle-aged and older Americans. Their BMI is 25. They were at the upper limits of normal for weight. They weren't quite obese. 40% had high blood pressure. 36 had impaired glucose tolerance. They were pre-diabetic. They'd had non-alcoholic fatty liver disease for about 8 years, and they'd been hyperlipidemic for 10 years. You give them all dietary advice, do baseline studies, randomize them to receive red yeast rice extract, 600 milligrams twice a day, and that would be equivalent to 10 milligrams of lovastatin, a prescription statin agent. And we have a presentation on red yeast rice extract, bergamot, amla, and delta-tocotrienol. These are green statins. Like the drugs, they will block H-nuclear reductase, blunt the generation of cholesterol, and downstream inflammatory mediators. So red yeast rice extract has been used in Chinese medicine for several thousand years. In China, it is a standard lipid-lowering cardiovascular therapy. It will lower cholesterol, not as much as the drugs, it's not as powerful, but all the benefits that statin therapy will afford you will be qualitatively recapitulated if you take red yeast rice extract. We block the generation of cholesterol, we block downstream activation of the enzyme NADPH oxidase, which generates free radicals, so we will block in part this maladaptive response to perceived infection that characterizes atherosclerosis. So it's a agent that many of my patients take. It's a standard therapy for me. So we have a standard therapy, red yeast rice extract, a green statin. We're going to compare that to PPC. They call it in China polyenylphosphatidylcholine, but it's the same material, PPC, which is phosphatidylcholine enriched in linoleic acid. So you dietary advice, you randomize them to get red yeast rice or PPC, repeat baseline measurements at 12 and 24 weeks, randomized double-blind protocol was followed. Neither the researchers nor the subjects knew who was getting red yeast rice extract, who was getting PPC. Cholesterol falls with both groups, as we would expect. HDL rises with both groups. Triglycerides fall, fasting sugar improves. Why does fasting sugar improve PPC? Because you're improving cell membrane function. The insulin receptor works better. Why does glucose fall with red yeast rice? Because you're lowering cholesterol, you're lowering oxidative stress. When you lower oxidative stress, you get better insulin sensitivity. They're both lowering sugar, but via different mechanisms. Liver chemistries, ALT drops in both groups. So when you have fatty liver, your transaminase values, your ALT and AST rise. There was an improvement in elaboration of these molecules. So that's an improvement of fatty liver. GGT is activated when you are recycling glutathione, the key antioxidant and detoxifier. So GGT was high because they were experiencing oxidative stress. They needed more glutathione. GGT falls because you're lowering inflammation, you're lowering oxidative stress with either of these agents. Tumor necrosis factor alpha, interleukin-6 are Th1 inflammatory cytokines. They are the product of nuclear factor kappa beta. They will also activate nuclear factor kappa beta. You can see both PPC and red yeast rice were equivalent in lowering inflammation in the liver. PPC and insulin receptor dynamics. We're going to take 13 cirrhotic patients. They were not consuming alcohol. Baseline studies of their red blood cell membrane composition, insulin receptor function. So you have these insulin receptors embedded in the cell membrane. If the cell membrane is functioning well, insulin receptor function should improve. If you have an old brittle cell membrane full of cholesterol, saturated fats, trans fats, you would not expect the insulin receptor to work as well. So you've got the cirrhotics, and you're going to then you do the baseline studies, treat them all with 2,000 milligrams of PPC IV over 2 hours, 4 consecutive days. Repeat assessments day 1 and 3 during the infusions and day 11 post-treatment with IV PPC. Red cell phospholipid concentration, of course, is going to rise with intravenous PPC. And even though you're stopping the infusion on day 4, it stays up for 2 weeks. The cholesterol to phospholipid molar ratio was high in the cirrhotics. When you have cirrhosis, you have trouble making cholesterol, but you have more trouble making phospholipid. So you have a high ratio of cholesterol to phospholipid, thus a stiff dysfunctional cell membrane. And of course, that falls with PPC, and it stays improved for 2 weeks. Insulin receptor binding was compromised in the cirrhotics because they had poor cell membrane function, because they had low levels of phospholipid relative to cholesterol in the cell membrane. If you flood them with phospholipid, you get improved insulin and insulin receptor binding. So insulin sensitivity improved with intravenous PPC. PPC has powerful antioxidant and anti-inflammatory effects. PPC maintains the integrity of our cell membrane. Thus, our cells are less resistant to oxidative and inflammatory damage. Let's now examine the role of PPC in mitigating ischemia reperfusion injury. Well, what is ischemia reperfusion injury? Consider if a cell or an organ or part of an organ is deprived of oxygen. Let's say you occlude one of the three coronary arteries. The heart muscle served by that artery will no longer have any oxygen. It will be unable to burn fatty acids efficiently to make ATP energy. As a result, you will generate metabolic acids, you'll generate free radicals, you'll generate superoxide. That superoxide will rapidly overwhelm your antioxidant defenses, and that superoxide will begin to damage your cells. And within 24 hours, that region within the heart will die. It will become irreversibly scarred. Well, you're not going to wait 24 hours. You're going to hightail it to the hospital. Your heart attack will be recognized. You'll undergo emergency angiography and stent placement. You'll be revascularized, and this heart muscle that is devoid of antioxidants will be resupplied oxygen, and you'll get a burst of oxidative stress. And damage to the heart will be accelerated by that burst of oxidative stress. The same phenomenon would occur if you receive a kidney transplant from a live donor. So they remove the kidney from the live donor. They have to put it on the helicopter and bring it to your hospital where you're going to receive the kidney. During that time interval, the kidney will not be receiving any oxygen. It will experience oxidative stress. It will run through all of its antioxidants. In fact, to mitigate this, they will soak the kidney in a bath of antioxidants. Let's say you have on-pump open heart surgery. During that 2-hour procedure, the heart's not getting any oxygen. It will begin to experience oxidative stress and cellular death. If the surgery is complicated, let's say it lasts for 6 hours, there will be irreversible loss of heart muscle. But of course, the surgeon will work expeditiously. They will limit the time on pump, and then they will start your heart up again and resupply the heart with oxygenated blood, and you'll experience an oxidative burst. Cardiac dysfunction in the surgical ICU is not due to insufficient blood supply. The heart has been revascularized. It's due to extreme oxidative inflammatory stress on the basis of reperfusion injury. And we talked about how we can mitigate this. So if you are going into open heart surgery and you take allopurinol to block superoxide generation via the xanthine oxidase system, or if you take coenzyme Q or vitamin E or vitamin C, you have a smoother postoperative course. So we can blunt ischemia reperfusion injury with antioxidant strategies. Let's see how PPC will work in attenuating this phenomenon. So we remember that phosphatidylcholine makes up 70% of our body's phospholipid pool. The cell membrane and the mitochondrial membrane is rich in phosphatidylcholine. Phosphatidylcholine will be depleted by ischemia and ischemia reperfusion injury because it'll absorb free radicals and become rendered inert and dysfunctional. So with ischemia reperfusion injury, we get oxidative stress, we deplete our phosphatidylcholine, we have cell membrane leakage, impaired energy generation, cardiac arrhythmia, irreversible damage. In ischemia reperfusion injury, we're going to lose our PPC, we're going to lose cell membrane and mitochondrial membrane integrity, and this will accelerate the death of the cell. So in this situation where we are going to lose PPC, could PPC supplementation protect against phosphatidylcholine dropout and cellular injury? Will PPC attenuate ischemia reperfusion injury? So here we'll do a study on renal ischemia reperfusion injury in 40 Sprague-Donnelly rats. You induce general anesthesia. You're going to occlude both renal arteries for 60 minutes, reperfuse for 6 hours, sacrifice and evaluate the kidney status. So this would be akin, if you had septic shock and your blood pressure falls to 60, you will not be perfusing your kidneys. They will experience ischemia, and then you resolve the septic shock. The kidneys are now reperfused with oxygenated blood. This experimental model would lend itself to a study of septic shock or the situation of septic shock in humans. Now, there's 3 different preoperative treatment strategies. Normal controls have sham surgery, no PPC. The surgical controls have real surgery. They experience ischemic reperfusion injury. Without PPC, the third group gets the surgery, but they're pre-treated for 10 days with PPC, 100 milligrams per day. BUN and creatinine will rise in kidney dysfunction. Irrespective of the cause of kidney dysfunction, we will see a rise in BUN and creatinine. And of course, this occurs with ischemia reperfusion injury, but it's attenuated in the animals that were pre-treated with PPC. AST, we think of that as a liver enzyme, but it's an enzyme in all of our cells, and the AST rose because of kidney damage. The cell membranes ruptured, the AST leaked out, and that was also attenuated with PPC. Superoxide dismutase was used up. Glutathione was used up in ischemia reperfusion injury within the kidney. Because you're generating all this superoxide, you're going to use up your superoxide dismutase and your glutathione defenses. And of course, this was attenuated with PPC because PPC has an antioxidant effect and it's blunting the generation of superoxide, and it's preventing cell membrane rupture in response to oxidative stress. Malondialdehyde is a marker of cell membrane oxidation. This would be akin to LDL oxidation or elevated lipid peroxides. It rises with ischemia reperfusion injury. There's an attenuation with PPC. Myeloperoxidase is released by white cells that are activated, generating free radicals, hypochloric acid, bleach. It's upregulated, and there's attenuation with PPC. This is the appearance of the kidney tissue under the microscope. This is the kidney in response to ischemia reperfusion injury without PPC pretreatment. These white areas are fluid collections that develop in response to the loss of cells. So you lose cells, you retain fluid. The animals that underwent the experimental ischemia reperfusion injury were treated with PPC, there's less cellular loss. Here we're going to stain for nuclear factor kappa beta translocation. It's not really obvious on these slides, but there's more darkness here, more nuclear factor kappa beta translocation, and of course more cellular loss in the animals that underwent the surgery versus those that had experienced ischemic reperfusion injury but were pre-treated with PPC. So now let's look at the effect of PPC in experimental cardiac ischemia reperfusion injury. You will remove the heart from a healthy rat and place it in a Langendorf perfusion device and create ischemia reperfusion injury. So you remove the heart and you put it in this perfusion chamber. You're pumping in oxygenated blood, you're draining the venous blood, and in this situation, the heart will function for several hours, and then you can study the effects of various treatments on the integrity of the heart, the ability of the heart to relax, the ability of the heart to contract. So you're going to perfuse the heart normally for 20 minutes. Then you're going to subject the heart to low flow ischemia, and that would mimic blocking the coronary arteries. That would mimic an experimental heart attack or the effects of prolonged open heart surgery. Then you're going to reestablish normal perfusion for 30 minutes. So we have ischemia, we have reperfusion, and you carry out this experimental ischemic reperfusion injury with or without pre-treatment with intravenous phosphatidylcholine, or I'm sorry, intracoronary phosphatidylcholine. So what you see, contractile force will attenuate over time without ischemia or reperfusion because the heart is in this artificial situation. Eventually it'll become dysfunctional. When you cut off the oxygen supply, the heart ceases to contract. It's not making any energy. If you resupply oxygen in the presence of phosphatidylcholine, contractile force recovery is superior than if you use a placebo solution, or they also used choline alone. Choline alone doesn't work. It's phosphatidylcholine that will work because it will absorb free radicals, it blunts inflammation, it maintains cell membrane integrity. Resting tension rises with ischemia. So if you don't have any energy, the heart cannot relax, it is stiff. We see normal resting tension in the normally perfused rat hearts. With ischemia, we have this inability to relax. If we reperfuse, this improves. particularly in the animals that receive phosphatidylcholine, percentage of the hearts experiencing arrhythmias will rise with ischemia, and this will attenuate more in the hearts that are pre-treated with phosphatidylcholine. These are difficult to understand graphs. It has to do with the ability of the heart to generate energy by burning fuels, and that is improved in the hearts that received phosphatidylcholine. So the ability of the heart to respond to ischemia, reperfusion, injury, to recover is enhanced with phosphatidylcholine. Now let's look at phosphatidylcholine and lipopolysaccharide-induced multiple organ injury. Now, lipopolysaccharide is the material of the cell membranes of gram-negative bacteria. So if you have septic shock, it's the lipopolysaccharide activating threat receptors on your cells, initiating nuclear factor kappa beta translocation, and this overwhelming elaboration of inflammatory mediators. And that's what drops your blood pressure and damages your organs and will eventually kill you. So we're going to take male Sprague-Dawley rats and randomize them to receive intravenous saline as a control, hydrocortisone, that is steroids, our most powerful pharmaceutical anti-inflammatory agent, phosphatidylcholine, which was 50% PPC, lipopolysaccharide to induce experimental septic shock, and then lipopolysaccharide with hydrocortisone or lipopolysaccharide with phosphatidylcholine. Sacrifice all the rats at 6 hours and evaluate markers of oxidative inflammatory stress, and you're going to look at histology. You're going to look at the liver and the lung under the microscope. Tumor necrosis factor alpha and interleukin 6 are Th1 cytokines. We would expect elaboration of Th1 cytokines in this situation of experimental septic shock. And indeed, they are elaborated. The animals that receive hydrocortisone and phosphatidylcholine, we see a lower level of Th1 cytokine elaboration. In other words, the hydrocortisone and the phosphatidylcholine are blunting activation of nuclear factor kappa beta, so we have a lower elaboration of these cytokines, which are maladaptive in this situation. Interleukin 10 is a equal and opposite anti-inflammatory cytokine. Whenever Mother Nature initiates inflammatory response, she initiates an anti-inflammatory response, and interleukin 10 rises with phosphatidylcholine. So the inflammatory response to septic shock is blunted. The anti-inflammatory response is augmented. Now let's look at tissue myeloperoxidase activity. What's myeloperoxidase? So if we're making all this superoxide and we are not able to neutralize it, we'll convert it to peroxide. Then we're going to activate this enzyme called myeloperoxidase to make hypochloric acid, which is like bleach. And you want to bleach the microbes, but you don't want to bleach your own tissue. So we're going to look at tissue myeloperoxidase activity. With saline, with or without hydrocortisone or phosphatidylcholine, the activity is low. These increases were not statistically significant. But if you add in lipopolysaccharide, you can see a big bump in myeloperoxidase activity in the lung, the liver, and the kidney. And this is blunted with hydrocortisone, and it's blunted with phosphatidylcholine. Let's look at white cell infiltration into the lung tissue. So in response to this inflammatory cytokine elaboration from the experimental septic shock, you're going to see all these white cells, they're stippled black within the lung tissue. Now, saline control, hydrocortisone, phosphatidylcholine by themselves do not cause inflammation. You do not see elaboration of white cells in the lung tissue. Here with septic shock you do, and then hydrocortisone and phosphatidylcholine will blunt infiltration of white cells into the lung tissue. Here we're going to look at white cell infiltration in the liver. It's not obvious on this slide, but there's more white cells in the liver with experimental septic shock, and this is blunted with both hydrocortisone and phosphatidylcholine. I think you're getting the idea that PPC, via its antioxidant and anti-inflammatory effects and its ability to stabilize and protect the cell membrane, will protect us from virtually any insult, because any insult that our organs will experience involves oxidative inflammatory stress. Now let's look at the benefits of PPC in the situation of obstructive uropathy. And this would actually be a good time for me to give you an update on Darren Walsh. If you've been listening to me speak over the last 20 years, you know about Darren. When our kids were little, we would host kids from Northern Ireland for the summer. This was part of Project Children. And a 747 would lift off from Belfast full of kids, half Protestant, half Catholic. They'd spend 6 to 8 weeks in the U.S. and get a break from the Troubles and also come to an understanding that Catholics and Protestants don't have to hate each other. Because in Belfast at that time, there was considerable strife. You know, we have this divisiveness between Republicans and Democrats in Washington, but they're not killing each other. And there were daily bombings and threats in Northern Ireland. It was really kind of a horrible place to grow up as a kid. Now, Darren was Catholic, and my wife is Catholic, and I'm Protestant. And Darren was very mistrustful of me. He assumed that I would be beating my wife because I was a Protestant and Protestants are all bad people. Well, of course, that changed pretty quickly. Darren warmed up to me and he had a great summer in Toledo. We got to know Darren. We got to know his family. We got to know his nephrologist, and he wound up spending every summer with us. And when he had kidney failure on the basis of ureteral obstruction, he had recurrent infections when he was a kid. And when he got to the point where his kidneys were failing, we actually had a mini dialysis unit set up in our home. He would dialyze himself at night, play with the kids in the day. Anyways, Darren got a kidney transplant. He grew a foot in a year. He's married. He's an IT guy. He's got twins. He's doing really well. But anyways, back to our story. PPC effect in obstructive uropathy. You're going to take rats, assign them to experimental groups. One group undergoes incomplete unilateral ureteral obstruction. You implant the ureter into the psoas muscle in the back. So this would be kind of like a kidney stone. There's an obstruction to the flow of urine. Pressure will build up in the kidneys. This will damage the kidneys and eventually destroy the kidneys. Another group gets the experimental ureteral obstruction and they're pre-treated with PPC, 100 milligrams a day for a month. Third group's sham surgery. Euthanize all the animals at 30 days and evaluate kidney status. Renal reactive nitrate species. This would be a marker of oxidative stress, superoxide. Rises in this situation with unilateral ureteral obstruction. This is attenuated if the animals are pre-treated with PPC. Malondialdehyde is also a marker of oxidative stress akin to lipid peroxides or oxidized LDL. It rises, and that is attenuated with PPC. Superoxide dismutase is our primary antioxidant enzyme. It will be used up if we're overwhelmed with superoxide. You're overwhelmed with superoxide in this situation of experimental ureteral obstruction. And this is not only attenuated, renal superoxide dismutase elaboration is increased with PPC because PPC can absorb a free radical hit without becoming a free radical itself. PPC supports the methyl cycle. The methyl cycle generates glutathione and other antioxidants. So of course PPC is going to support our antioxidant defenses. Glutathione is depleted. Glutathione is the middle linebacker of our antioxidant detox systems. It's going to be depleted with oxidative stress. This is attenuated with PPC because PPC has an antioxidant effect. PPC supports the methyl cycle. The methyl cycle generates glutathione. Interleukin-1 and interleukin-6 are Th1 cytokines. So there's a abnormal immune response to what it perceives as infection, damaged tissues with the ureteral obstruction. These cytokines rise, and this would also reflect nuclear factor kappa beta translocation. So they go up, and that's attenuated with PPC. The same thing with tumor necrosis factor alpha. Another cytokine that mediates fibrosis, transforming growth factor beta, is increased, and that's mitigated with PPC. Now, this is nuclear factor kappa beta expression. You can see it upregulates with ureteral obstruction. The body is mounting an inflammatory response, and that's mitigated with PPC. Leukocyte infiltration. Fewer white cells are called in. When our cells experience oxidative stress, irrespective of the cause, white cells will infiltrate, they will activate, they will make inflammatory mediator cytokines, free radicals. This is blunted in the animals that receive PPC. Renal T lymphocytes are going in. This is the same physiology as in your coronary arteries. You get oxidative inflammatory stress. white cells are called in, lymphocytes are called in. You're mounting an immune response here against damaged kidney tissue. Same situation, you're mounting an immune response against oxidized LDL in the coronary arteries if you have atherosclerosis. Same physiology, PPC will blunt. Macrophages, these come in to kind of clean up the debris, and these activated macrophages are the ones that are involved in atherosclerosis. They're involved in kidney damage, and this is blunted with PPC. Renal fibrosis, due to oxidative inflammatory stress, cell loss, you're getting irreversible scarring, and that is blunted with PPC. Now let's talk about the use of PPC in the treatment of chronic liver disease, which I'm going to term cardio-hepatology. Supplements that blunt oxidative inflammatory stress and improve methyl cycle dysfunction in the heart and great vessels are going to also blunt oxidative inflammatory stress and resolve methyl cycle dysfunction within every organ system in the body. Many of the treatments that I use to treat heart disease are thus of value in liver disease. Perhaps I could get together with Dr. Sinatra or perhaps another physician and we could come up with another book, Reverse Liver Disease Now. The liver is found beneath the lungs, essentially straddling the stomach. The liver receives oxygenated blood and arterial blood supply from the heart. The products of liver metabolism and deoxygenated blood drain from the liver through the hepatic vein back into the heart. Everything that we take in our diet is processed in the liver. It drains to the liver through the portal vein. And the liver's job is to assimilate and utilize the foodstuffs and detoxify any toxic molecules that we might take in. What are the functions of the liver? Multiple. Cholesterol generation, glucose metabolism, detoxification, making bile acids, generating amino acids. It helps with the absorption of vitamins. Obviously, the liver is critical for proper health. And you can think of the liver as one big cell membrane. Most of our biology occurs on cell membranes. The enzymes and the pumps and the channels are all embedded within the cell membrane. So proper cell membrane function is critical for proper liver function. Do we know how to improve cell membrane function? Yes. Will PPC help here? Now, Napoleon is often misquoted as saying an army marches on its stomach. That's really not what he said. He actually said an army marches on its liver. And the U.S. Army has a comparative advantage here because the U.S. Army has the most effective and the best looking hepatologist, and that would happen to be Major Catherine Roberts. Now here is Lieutenant Catherine Roberts and I finishing the Cincinnati Flying Pig Marathon, and here is Catherine graduating from medical school. And this was pretty cool because I got to participate. So this is me, and we pulled out my graduation gown from medical school. And when you graduate, these little hoods that you see here are put over your head. And I got to stand up there in front of the room full of people and put the hood over Catherine. And that was kind of like one of the peak experiences of my life. In a separate ceremony, an hour later, Lieutenant Roberts is being promoted to Captain Roberts. And in this ceremony, someone close to you will remove your lieutenant's bars, and then the general will put on the captain's bars. And my father, who's a retired pediatric allergist, was an Army captain. He was drafted in medical school. They let him finish medical school, do an internship, and they put him in Paris in a NATO hospital. And so on weekends, we would tour the capitals of Europe, and I don't remember a thing because I was like 2 years old. But the one thing I do remember is I would play on the tank traps on the beach. So this is like 1957, and the tank traps from World War II had not been removed. So anyways, my dad gets to flip Catherine's bars off. The general puts on the captain's bars. That was pretty cool. Now here's a picture of now Major Catherine Roberts drinking a Heineken with one of her friends. Now, why is a liver doctor drinking Heinekens? Well, Major Roberts was sending me a message, and there's a cute story here. So we have 5 kids, and when they were little, we would have a party the day after Christmas, St. Stephen's Day, another reason to have a party during the holidays. and the kids would drink soda pop, the adults would drink adult beverages. Well, then years go on, the kids are going to school, they're coming home, they want to drink beer. They're 18, they're allowed to drink beer. So they would drink a beer appropriate for college kids. It was something I think was called Bud Natural Light. They'd call it Natty Light. And this was kind of a beer that no self-respecting adult would drink, but it was cheap and it was okay for the college kids, and the adults would have an adult beverage such as a Heineken. Well, then the years go on, the kids are graduating from school, they're getting married, they're going to graduate school, they're in the workforce. So there's going to be a time when Dr. and Mrs. Roberts become Cindy and Jim, and the kids are full-fledged adults and they can drink Heinekens. So we need to have a policy here, a cutoff. So I created some rules that we had a lot of fun enforcing. And the rule was, if you'd completed your education, you'd reached your terminal degree, you're in the workforce, or you're having a family, you're an adult, it's Jim and Cindy, you get a Heineken. But if you're still in school, if you're still in training, you get the Bud Natural Light. And this was a lot of fun because there'd be a couple, one had graduated, was working or raising a family, the other was still in graduate school. So the one still in school got the Bud Natural Light, the one who had graduated got the Heineken. So Catherine had to wait a long time to get her Heineken because she did this 9-year program at the University of Cincinnati, 5 years of biochemical engineering, 4 years of medical school, then 3 years of internal medicine, then 3 years of gastroenterology, and then a year of transplant hepatology. That is her area of expertise. So on her very last day of her hepatology fellowship, she and her friend went out and they had Heinekens to let me know that she had finally completed her training. And do you think I'm just a little proud of my little girl, Major Roberts, the Army hepatologist? You bet I am. So now we're going to talk a little bit about PPC in liver disease, and we'll start in cirrhotic spur cell disease. And these studies will also demonstrate how PPC changes for the better cell membrane function. We'll take 30 subjects with advanced cirrhosis. They have liver failure, 10 healthy controls. 12 of the 30 cirrhotics had spur cell disease. That means 30% of their cells had this spur cell appearance. Now, the normal individuals have, your red cell is this biconcave disc, and it has this configuration because the red cell membrane is healthy. It has a favorable ratio of phospholipids to cholesterol to saturated fats. Now, in cirrhosis, the liver cannot make cholesterol, it cannot make phospholipids, the cell membrane is stiff and crenellated, so you have this spur cell appearance. So the spur cell red blood cell membrane is characterized by a relative increase in free cholesterol, decreased esterified cholesterol, reduced phospholipids, increased saturated versus unsaturated fatty acids. The cell membranes are stiff and dysfunctional, they're crenellated, they have this spur cell appearance. So we're gonna do the baseline studies, treat the spur cell cirrhotics and the controls with intravenous PPC, 2,000 milligrams a day, 5 days in a row, repeat the baseline assessment. Now at baseline, the healthy controls, none of them had spur cells. Those with cirrhosis, 40% had spur cells. So we're gonna take the cirrhotics with spur cells, and we're going to see that at baseline, 60% of their cells were abnormal. They had the spur cell morphology. After just 5 days of PPC, that falls down to 24%. So we're acutely improving cell membrane function with intravenous PPC. As you are now aware, when we administer PPC, it first loads up into the HDL, where it will stimulate the enzyme lecithin cholesterol acetyltransferase, LCAT, to promote cholesterol esterification. And this is the means through which the HDL primed by PPC will remove cholesterol from the artery wall. It will esterify it with linoleic acid, load it up in the HDL. The HDL will take it out of the body through the liver. But every cell in the body is going to pick up PPC. So we've got these cirrhotic spur cells that have this abnormal morphology because they have a low phospholipid to cholesterol ratio. We flood them with PPC, we rectify this imbalance, and then the spur cell morphology will be corrected to the normal morphology because we're improving cell membrane function acutely. Let's look at serum lipids. In the cirrhotics, their cholesterol was relatively low because the cirrhotic liver cannot make cholesterol. Triglycerides are high because they have insulin insensitivity, and they're not making phospholipids, they're not making phosphatidylcholine. Now let's look at the red blood cell lipid content, which would determine whether a cell is spur or normal. The relative to healthy red cells, the spur cell red cell has high cholesterol, low phospholipids, and the cholesterol to phospholipid ratio is increased. And it's not the absolute values, it's the ratio. What types of fatty acids are in the red cell membrane phospholipids? The spur cells have more stearic acid. That is a saturated fatty acid than healthy controls. And if we treat them with PPC, that rectifies. Linoleic acid, that is the fatty acid in PPC. That is the desirable fatty acid. You can see it's low. It's markedly depressed in the cirrhotics because they're not making phospholipids. And if you treat them with intravenous PPC, that imbalance is rectified. The red cell cholesterol to phospholipid ratio is elevated in spur cells versus healthy controls. In the spur cell patients being treated with PPC, the cholesterol to phospholipid ratio falls. And why? Because we're stimulating LCAT. We talk about LCAT with respect to removing cholesterol from the artery wall and loading up in the HDL as cholesterol linoleate, but it's active throughout the body. So we're stimulating LCAT activity with PPC, and so spur cell LCAT activity is stimulated, and thus we're going to esterify cholesterol. We're going to be lowering the free cholesterol within the cell membrane. We lower the free cholesterol content. We increase the phospholipid content. We get a lower cholesterol to phospholipid ratio, and the spur cell dysfunction results. Now, these graphics are tedious, but please hang in there with me because they illustrate how PPC leads to lipid exchange, not just in the spur cells, but within every cell membrane in the body and within our HDL and LDL particles. So let's look at the ratio of free cholesterol to cholesterol ester at baseline and with PPC. So in the controls, we treat them with PPC. We will promote cholesterol esterification because we're going to be stimulating LCAT to esterify cholesterol. Thus, the free cholesterol to cholesterol ester ratio will fall. In the cirrhotics with spur cells, they are not making phosphatidylcholine. They're not esterifying their cholesterol. They have a very high free cholesterol to cholesterol ester ratio within the HDLs, and then that is attenuated with PPC. Similarly, the free cholesterol to phospholipid ratio in normal healthy people improves with PPC. The cirrhotics have an elevated free cholesterol to phospholipid ratio. That's why they have their cell membranes are dysfunctional, why they're spur in morphology. You treat them with PPC, there's an improvement. Now, this is in the HDL. The same thing is occurring in the red cells. Now, let's look at the LDL. Now, the spur cell patients have a high ratio of free to esterified cholesterol in their LDL that is improved with PPC. They have a high ratio of free cholesterol to phospholipid that is improved with PPC. Now let's look at the fatty acid composition within the phospholipids in HDL. In the healthy controls, you have a little bit more unsaturated linoleic acid versus saturated stearic acid. That's normal and healthy. It becomes more normal and more healthy with PPC. The relative percentage that is saturated falls, unsaturated increases. That's favorable. In the spur cells, you can see they have lower levels of linoleic acid. If we treat them with PPC, which is enriched in linoleic acid, you go pretty much back to normal. The HDL cholesterol ester fatty acid composition, if you treat the healthy controls with PPC, there's more linoleic acid representation. In the spur cells, in the cirrhotics, they have lower representation of linoleic acid that is improved if we treat with PPC. So PPC promotes phospholipid exchange, replacement of saturated fatty acids in phosphatidylcholine with unsaturated fatty acids. The phospholipid component of the cell membrane functions better. LCAT is stimulated. Now, we talked about LCAT to promote reverse cholesterol transport, but LCAT mediates lipid exchange in every cell in our body. The HDL, the LDL, the red cells, any cell membrane. If we flood the system with PPC, we're going to stimulate LCAT and promote favorable phospholipid exchange. So free cholesterol is esterified with unsaturated fatty acids. And of course, within the HDL and the artery wall, this promotes reverse cholesterol transport. Red cell free cholesterol falls, esterified rises, phospholipid content increases. Red cell membrane fluidity improves, first cell morphology attenuates. Same phenomenon in HDL, LDL, and all other cells. PPC promotes a favorable lipid exchange. Now, let's get back to hepatology. Let's look at the PPC effect on SAMe, S-adenosine-methionine, the universal methyl donor, in alcohol-induced oxidative stress. So we have one group of rats on the controlled diet. They receive safflower oil. That contains linoleic acid, but not as phosphatidylcholine. Another group gets a controlled diet and PPC, which is linoleic acid enriched with phosphatidylcholine. A third group is rendered alcoholic. They get 36% of their calories as alcohol, and they get safflower oil. The other group is rendered alcoholic, and they get PPC, phosphatidylcholine with linoleic acid. Euthanize all at 8 weeks and evaluate liver biochemistry. Alcohol intake led to a fatty liver, as expected, and this was greatly attenuated with PPC. Now, we've talked about functions of the methyl cycle. One of the functions is to maintain a high level of SAMe to SALI. SAMe, S-adenosine-methionine, is the universal methyl donor. When SAMe gives up a methyl group, it creates SALI, S-adenosine-homocysteine. It's not the absolute values, but the ratio that determines whether we can methylate or not. Now, we use up a great deal of SAMe generating phosphatidylcholine. To make one phosphatidylcholine molecule, we have to spend 3 SAMes. We also use up SAMe generating glutathione, which is our chief antioxidant. So in alcoholic liver disease, the liver cannot make phosphatidylcholine. We call on the methyl cycle to make more phosphatidylcholine. The liver's experiencing oxidative stress. We call on the methyl cycle to make more glutathione. So we're going to have methyl cycle dysfunction. Here's an example. This is a physician with methyl cycle dysfunction. A very low level of SAMe, a high level of SALI, and because we know that the methyl cycle spends 2/3 of its SAMe generating creatine for muscle and phosphatidylcholine for cell membrane support, we treated her with creatine and phosphatidylcholine, and we rectified the situation. So we'll get back to this animal model. These are alcoholic animals, and they're experiencing oxidative stress. And they can't make phosphatidylcholine. There's going to be a great strain on the methyl cycle, and we would expect that these alcoholic animals would be low in SAMe and high in SALI because they're experiencing methyl cycle dysfunction. In a sense, alcoholic liver disease and non-alcoholic fatty liver disease is simply a methyl cycle dysfunction in the liver. So what do we see? Yes, we see depletion of SAMe in the alcoholic animals. Now, if you treat healthy animals with PPC, we actually increase SAMe because we spend a lot of our SAMe making PPC. If we supply PPC, we spare SAMe. And the alcoholic animals that are treated with PPC, there's relative preservation of SAMe versus the untreated alcoholic animals. Glutathione, our chief antioxidant, will be depleted. We're going to be making 4-hydroxyenol. That's a marker of oxidative stress. In the situation of alcoholic liver disease, we're generating free radicals, we're depleting our glutathione. PPC increases glutathione, and PPC attenuates the reduction in glutathione due to alcoholic oxidative stress. 4-hydroxyenol, a marker of oxidative stress, rises with alcoholic liver disease. PPC actually lowers 4-hydroxyenol, and the elevation of 4-hydroxyenol due to alcoholic liver disease is blunted if you treat the animals with PPC. Here we can see that the greater the level of oxidative stress, the lower the SAMe. Conversely, the greater the level of SAMe, the lower the level of oxidative stress. When the methyl cycle is functioning properly, you have plenty of SAMe, you have high glutathione. When we have oxidative stress, low glutathione, we have depletion of SAMe. the roles of the methyl cycle are to generate a high level of SAMe to SALI and to generate glutathione to neutralize oxidative stress. In an alcoholic liver disease, we are straining the methyl cycle to generate more phosphatidylcholine, to generate more glutathione. We're going to have methyl cycle dysfunction. If we intervene with PPC, we can neutralize the adverse effect of alcohol-induced oxidative stress on methyl cycle dynamics. PPC protects against alcohol-induced fatty liver disease and SAMe depletion by providing an axon effect, blunting the need to spend SAMe to generate glutathione, spare SAMe otherwise used up to generate phosphatidylcholine, so we can maintain proper methyl cycle dynamics. DLPC in alcohol-induced mitochondrial injury. We're going to take male rats, assign them to feeding groups, controlled diet, and DLPC. Now the PPC that we use is 80% linoleic acid. For experimental purposes, you can generate PPC that is 100% linoleic acid. That's dilinolenyl phosphatidylcholine. Another group is rendered alcoholic. Alcohol is 36% of the calories. Another group gets the alcoholic diet and DLPC. Another group gets the alcoholic diet and PPC, which is what we're using, which is 80% as opposed to 100% linoleic acid. Euthanize all at 8 weeks and evaluate the liver biochemistry. This is the mitochondria. This is the fuel cell where we generate energy by abstracting electrons from molecules of glucose and fatty acids. And in the situation of oxidative stress, the mitochondrial membrane will leak and rupture, and that is the signal for the cell to die. So we want to maintain the integrity of the mitochondria. Here we're going to see if PPC or DLPC will protect the mitochondria from alcohol-induced oxidative stress and mitochondrial injury. Here we're going to look at the ability of the mitochondria to generate energy, to generate ATP by oxidizing, by burning certain substrates. In alcoholic liver disease, there's going to be mitochondrial dysfunction. The mitochondria is unable to generate energy by burning palmitic acid bound to carnitine or glutamate, another energy substrate. And this is attenuated if the animals are also treated with PPC or DLPC. Cytochrome oxidase is an enzyme involved in mitochondrial function. Its expression is decreased. In alcoholic mitochondrial dysfunction, that is attenuated in the animals that receive PPC or DLPC along with the alcohol. PPC in carbon tetrachloride-induced liver fibrosis. Now, carbon tetrachloride is a chemical that is used in the dry cleaning industry. It used to be used, and dry cleaners would present with liver disease from carbon tetrahydrochloride-induced liver dysfunction and fibrosis. Will PPC protect against that? Another animal study, genetically normal male rats assigned to experimental groups. Controlled diet with PPC, controlled diet with carbon tetrachloride. They would inject it into their abdominal cavity twice a week. Controlled diet, poisoned with carbon tetrachloride, and they're receiving PPC orally. Euthanize all at 8 weeks and evaluate liver biochemistry. With carbon tetrachloride poisoning, you're going to get hepatomegaly. The liver is going to swell. This is attenuated with PPC. Carbon tetrachloride exposure leads to liver enlargement and liver dysfunction, and it does so via the mechanism of toxin-induced oxidative stress. F2 isoprostanes and 4-hydroxyenol are markers of oxidative stress. We see low levels of oxidative stress in the control animals. Animals treated with PPC, there's no change. However, if you expose the animals to the liver toxin, carbon tetrachloride, there's going to be a great deal of oxidative stress. You see a spike in F2 isoprostanes and in 4-hydroxyenol. The animals that receive the toxin, carbon tetrachloride, and who are co-treated with PPC, you can see there's a dramatic attenuation in oxidative stress. Why? The linoleic acid within PPC will absorb a free radical hit without becoming a free radical itself. PPC provides an antioxidant effect. Carbon tetrachloride exposure leads to oxidative stress, cellular dysfunction, cellular death. And this leads to liver fibrosis involving the deposition of collagen, which will eventuate in cirrhosis. In the control animals and the control animals that receive PPC, there's low levels of oxidative stress, there's no fibrosis, there's no collagen deposition. In the darkened squares, those are the animals that receive carb-tet. They have more oxidative stress, more fibrosis. The darker circles are the animals that received carb-tet, and they would be exposed to oxidative stress, but they are co-treated with PPC. There's an attenuation in oxidative stress, less cellular loss, less fibrosis, a lower risk of progression into toxin-induced cirrhosis. In this study, we're going to look at the effect of PPC in experimental NASH. That's non-alcoholic steatohepatitis. That's basically inflammatory fatty liver. So we'll take male rats assigned a 4-week treatment protocol. Standard control diet, they're not going to have fatty liver or NASH. The NASH diet group receives a terrible diet. It's like fast food, 3 meals a day, 10% lard, 5% egg yolk powder, 1% cholesterol. They're going to develop inflammatory fatty liver, NASH. Another group gets the NASH diet, and they're also treated with PPC, weeks 2 to 4. Euthanize all at 4 weeks and evaluate liver structure and biochemistry. Now, we start with the normal liver. If we take in too much carbohydrate or too much alcohol, we're going to get fatty liver. 50% of Americans have fatty liver. As the world is industrializing, we're not eating normal foods. We're eating high sugar diet. We're getting high fructose corn syrup. Half the people in the world now probably have fatty liver. Fatty liver by itself is benign. It's not going to kill you until it progresses to NASH, which occurs when oxidative inflammatory stress ensue in the fatty liver. NASH means you're on your way to cirrhosis and aggressive action is required. So if you come in with fatty liver and the typical patient is overweight with belly fat, high triglycerides, insulin sensitive, many of you have fatty liver, we want you to change your diet, lose weight, take nutritional supplements. But those of you who have NASH, it is imperative that we take action, because if not, you're going to progress to cirrhosis. Now, I've had patients who are type 2 diabetics, they're overweight, they have fatty liver, they went on to NASH, and then later, 20 years later, they die of cirrhosis. They never had a drop of alcohol, but they had fatty liver that progressed to NASH and cirrhosis. So how do we determine whether you have NASH? Well, the traditional approach is to do a liver biopsy. Well, liver biopsies are expensive, there's a small risk. So our daughter, Major Roberts' research interest is the non-invasive identification of who has NASH. So they would take large groups of people, they would do different scans using CT scans and MRI, they would do liver biopsies and correlate the findings, and they're working on an approach where we can non-invasively determine who has NASH, who doesn't, who needs a liver biopsy, and who does not. But anyways, we've got the initial hit here in NASH is fatty liver, too much sugar, high fructose corn syrup, and you're getting fatty liver. Then the secondary hit is oxidative stress. And so many phenomenon in our environment cause oxidative stress. So you have oxidative stress on top of fatty liver, and then you get NASH, inflammation, fibrosis, and you're going to progress to cirrhosis. So back to our experimental model, one group of the animals go on the NASH diet, another group gets the NASH diet, and we're going to see if PPC will attenuate the development of NASH in response to a poor diet. So we get hepatomegaly with the NASH diet, and this is attenuated with PPC. Liver weight index, the weight of the liver or the rest of the body increases. That is attenuated with PPC. Liver chemistries, AST and ALT, these are enzymes within our cells when the cell membrane is dysfunctional due to oxidative inflammatory stress, as will be occurring in NASH. They will rise. This is attenuated with PPC. Liver lipid content, we have insulin insensitivity with the NASH diet. We have high triglycerides, high cholesterol within the liver. This is prevented if you treat the animals with PPC along with the NASH diet. Th1 cytokines, again, there's an immune response occurring in the liver of the individual, of the animals with non-alcoholic steatohepatitis, and you have high levels of tumor necrosis factor alpha, interleukin 1 beta. This is attenuated with PPC. Why? Because PPC is blocking nuclear factor kappa beta translocation. So no matter the cause of oxidative inflammatory stress, the deleterious amplification of the inflammatory response carried out via the nuclear factor kappa beta pathway is attenuated with PPC. It works in the heart, it works in the arteries, it works in the kidneys, it works in the liver, it works in the brain. As you now understand, NASH is fatty liver plus oxidative stress. So in NASH, there's a high free radical burden and a depletion of superoxide dismutase. So you're making all these free radicals, getting this high free radical burden. You're going to use up your superoxide dismutase dealing with this excessive free radical generation. Both of these abnormalities are attenuated with the NASH diet plus PPC. Nuclear factor kappa beta is activated with the oxidative stress of NASH because oxidative stress leads to inflammatory stress via the nuclear factor kappa beta pathway leads to more oxidative stress. This is blunted with PPC. So PPC will blunt nuclear factor kappa beta translocation, thus fewer inflammatory and oxidative mediators. The linoleic acid and phosphatidylcholine will absorb a free radical hit without becoming a lipid radical itself. PPC stabilizes the cell membrane, so there's less leakage of AST and ALT. PPC will stabilize the mitochondrial membrane, so it won't leak and the cell will not commit suicide. It won't commit apoptosis. So NASH is fatty liver plus oxidative stress. PPC also helps the liver break down fat, so you have less fat storage. PPC lowers oxidative stress. Less fatty liver, less oxidative stress, less tendency to progress to NASH and on to cirrhosis. PPC in chronic active hepatitis. We'll take 30 patients with chronic active hepatitis. They did not have hepatitis B. Thus, these patients probably all had hepatitis C. This is an older paper before we had lab studies to demonstrate hepatitis C. So they have chronic active hepatitis, not hepatitis B. They're all receiving standard immunosuppressive therapy, prednisolone and or azathioprine, active disease by biopsy. So you do a liver biopsy, baseline lab studies, randomize these patients to receive PPC, lipostabile, 3,000 milligrams a day, or placebo. You're going to repeat the biopsy at 12 months, and a standard double-blind protocol was followed. What do you find here? AST is a liver enzyme. AST will be elevated in the situation of chronic liver disease over a 1-year time period. In the placebo group with active hepatitis, the AST rose. It did not rise as much in the patients with active hepatitis being treated with PPC. Albumin is a beneficial protein made in the liver. We want to see a high albumin. It rose in both groups. There was no advantage here to PPC. Bilirubin rises in the situation of liver failure. A rising bilirubin reflects liver disease, just like a rise in butyric creatinine reflects kidney disease. Over the 1-year period with placebo therapy, bilirubin rose. It actually fell with PPC. Improved sense of well-being, 62% with PPC, 43% with placebo. They repeated the biopsies, and the biopsy was worse over 1 year with placebo therapy. The biopsy had improved with PPC therapy. Here we're going to look at the utility of complementary therapy with PPC plus interferon gamma in the treatment of chronic active hepatitis C. 129 patients with chronic active hepatitis C. Their lab studies abnormal. ALT, the liver chemistry, was greater than twice normal. All had active disease by biopsy. Baseline studies, you're going to treat them with interferon gamma, 3 doses a week over 24 weeks. Interferon gamma is a Th1 cytokine. It's our body's most powerful antiviral defense. And this interferon gamma is made in the laboratory, administered to these individuals to help their immune system kill the virus. That was sort of the standard therapy at the time for chronic active hepatitis C. And then you randomize them to receive, along with interferon gamma, placebo or PPC, 800 milligrams a day. Then you reevaluate at 24 weeks. If the ALT, the liver chemistry, fell by greater than 50%, you were considered a responder. They would treat you for another 24 weeks. If it didn't fall greater than 50%, you were a non-responder and you were dropped from the study. Multi-center double-blind protocol followed. Serum ALT at 24 weeks. In the placebo group, it fell by 50% in 51% of the subjects that received interferon alone. There was normalization of 36%. If you get complementary therapy, PPC and interferon gamma, there's a decrease greater than 50%, 71%, normalization 44%. At 48 weeks in the placebo therapy, no significant change. In the PPC group, decreased by 50%, 34%, normalization 41%. So with respect to lowering ALT, the liver chemistry, there was a synergy between PPC and interferon gamma. Why? PPC improves cell membrane function. It lowers inflammation. It lowers oxidative stress. It protects against mitochondrial dysfunction. So of course it makes sense that PPC would synergize with active antiviral therapy in this chronic inflammatory disease, hepatitis C. To summarize the cardio-hepatology section, hundreds of papers published in the European and Russian literature describe benefits of PPC in essentially all known liver disease states. PPC protects the liver from toxic exposure, be it excessive alcohol, mushroom poisoning, exposure to industrial chemicals such as carbon tetrachloride, or prescription agents such as drugs used to treat tuberculosis, Tylenol overdose, anesthetics. PPC is of value in fatty liver, blunting its progression to NASH and cirrhosis. We showed that PPC is of value in viral hepatitis. How does PPC protect the liver? The same way PPC protects every cell in the body, stabilizes the cell membrane, improves cell membrane function, antioxidant, anti-inflammatory effects, stimulates enzyme function, and PPC provides in the liver an anti-fibrotic effect. How could PPC be used to help Major Catherine Roberts carry out her charge to optimize the hepatic health of the U.S. military? This is of geopolitical importance, of course, because as we all know from Napoleon, an army travels on its liver. Well, these young men and women in the service tend to drink beer, and if they drink too much beer, they may experience fatty liver that would progress on to NASH, and that would compromise their health and their performance on the battlefield. Thus, the first military that comes up with a health-promoting beer will have an advantage. And if you don't think the Russians and the Koreans and the Chinese are working on this, well, you would be mistaken. Ladies and gentlemen, we are involved in a beer race. So we need to come up with a health-promoting beer to give the U.S. Army a comparative advantage. So Major Roberts and I have been working on this, experimenting with different food additives to make a beer less likely to cause fatty liver. We put a lot of energy into this, and of course the beer has to taste good. We're not going to serve up like Natty Light. We want to serve up something good for the servicemen. So anyways, we came up with a health-promoting beer, and we met with the colonel in the Pentagon, and we were then going to move up and meet a general, and the general got deployed. It's very frustrating. You meet with someone at the Pentagon, and they get transferred out. So we were getting frustrated, so we decided to turn to our ace in the hole, and that, of course, would be R.H. Poling. Dr. Poling, my good friend and colleague, Dr. Poling and I co-manage a number of patients. Poling's got 10 kids, and they all work in Washington. They're the chiefs of staff for senators and congressmen and congresswomen. They kind of really run the show and tell the elected representatives what to do. And Poling's got 2 brothers and 2 sisters. They each have 10 kids. They also work in Washington doing the same thing. Every Saturday night, they have a conference call that Poling chairs, and they discuss what direction the government should take next week. So, you know, when bills come out of Washington don't make any sense, well, now you know why. When you talk about the deep state, that's really the Poling family. Now, Poling's a good guy. He's a really smart physician, but it kind of troubles me to have all this power wielded by one unelected official. But anyways, that's the deep state. But we can take advantage of Poling's connections, and we asked him to get us into the Pentagon. And indeed he did. We met with a colonel, we met with a general, and then we were introduced to a meeting in the White House. Now, President Trump was out of town. He was doing something else that was kind of important. I think he was meeting with Kim, the Korean guy. But anyways, we met with Ivanka and Jared, had a good conversation, and they're good friends with Freddie Heineken IV. So we worked with the Heineken food scientists on our health-promoting beer, and we now have a beer to offer the U.S. servicemen so they can drink beer without getting fatty liver, and we decided to call it Heinekol, PPC enriched, Army approved beer, so now you can drink beer and not get fatty liver. Now, I know sometimes you don't know when I'm kidding and when I'm being serious, and I kind of leave you hanging because that makes it kind of fun. But just in case some military colonel or general is watching this, here I'm only kidding. I don't want to get my daughter in any trouble. Now, let's look at PPC in other inflammatory conditions of the GI tract. PPC and gastric mucosal protection. We're going to take healthy rats and we're going to put them on a carb-rich diet, bread rolls like you get at a restaurant for 3 days to sensify the mucosa, the gastric lining, to noxious stimuli. So a high-carb diet, lots of gluten, will sensitize the upper GI tract to inflammation. Then assign these rats to receive by gavage, that's a nasogastric instillation, aspirin, or other non-steroidal anti-inflammatory agents, diclofenac, indomethacin, piroxicam, with or without phosphatidylcholine. And they used phospholipon, which is like the PPC we use, except it doesn't have quite as much linoleic acid. Euthanize the animals 3.5 hours later and look at the gastric mucosal lining, and you create an ulcer index. 0 is no lesions, 5 is perforation. The greater the score, the greater the ulceration, and the greater the upper GI tract inflammation. Now, arachidonic acid is converted by the enzyme cyclooxygenase into mediators of inflammation. So we get arachidonic acid from a diet that is high in meat and dairy. It is an unsaturated fatty acid. It is pro-inflammatory. Cyclooxygenase will convert it into inflammatory mediators that cause pain, fever, and swelling. So those of you with aches and pains, you're taking non-steroidal anti-inflammatory agents such as ibuprofen, and that is blocking conversion of arachidonic acid. Thus, you have less pain and inflammation. However, arachidonic acid is also metabolized by another variant of cyclooxygenase into maintenance molecules that maintain the integrity of the GI tract and the kidneys and the immune system. So when we take ibuprofen or aspirin and knock out cyclooxygenase, yes, we get lower generation inflammatory mediators, we have less joint pain, we have less fever, we have less edema, but we're also damaging the GI tract and the kidney. So if you take too much aspirin, if you take too much ibuprofen, you're going to get peptic ulcer disease, you're going to get kidney disease. So that's a problem. Now, will PPC protect against this? So let's look at the ulcer index with aspirin. With low-dose aspirin, there was little inflammation. PPC or the phospholipon therapy had no effect. But if we increase the dose of aspirin, we get increased tendency to gastric ulceration. This was dramatically attenuated with PPC. So the negative effect of aspirin on the upper GI tract was attenuated with concomitant PPC therapy. With indomethacin, with high-dose indomethacin, we use indomethacin to treat acute gout. And it'll quiet down your acute gout, but it can also ulcerate your stomach. This is attenuated PPC. Diclofenac and piroxicam are other nonsteroidals. The greater the dose, the greater the degree of upper GI tract ulceration, and there's protection with PPC. How is it working? The stomach is making a protective layer of mucus to protect the gastric lining from any toxic molecules that we would ingest. This GI tract mucus lining is rich in phosphatidylcholine. Now, PPC and gastric mucosa protection. We're going to take 20 subjects with complaints of stomachache, like patients that come in saying, gee, I feel queasy, I don't feel very good. Why did they have stomachache? They were taking nonsteroidals, they were taking steroid medications like prednisone, or they just had a nonspecific illness. So you take these 20 subjects with stomachache, and treat all for 8 days with phosphatidylcholine. They use PPC here, 900 milligrams 3 times a day. And then you evaluate their complaints, how much stomach ache they're having. Their complaint index is 10, and over time it attenuates. Why? Because PPC will help you make gastric mucus. That will protect the lining of the stomach from the noxious stimuli that's causing your stomach ache. So PPC is of value in dealing with stomach ache and neutralizing upper GI inflammation on the basis of the anti-inflammatory therapies in common use. The entire GI tract generates a layer of mucus to protect the cells lining the GI tract from noxious molecules that we will ingest. Now, we make a lot of this mucus in the stomach and in the small intestine. We do not make it in the large intestine. The mucus layer in the large intestine is generated in the terminal region of the small intestine called the ileum, and it will cross into the colon. So we would expect that the lowest level of mucus would be in the rectum and anus, and within the colon there would be more in the cecum and the ascending colon. Ulcerative colitis is an inflammatory disease of the colon, and what's happening here, insufficient phosphatidylcholine-based mucus allows microbes and toxins in the gut to attack the bowel wall, causing these ulcers. And it's going to first start in the rectum, and then as it progresses, you see it move proximally in the colon. The reason the rectum is affected first is the rectum has the lowest level of protective mucus. Now, if we look at the phosphatidylcholine content of rectal mucus in individuals with Crohn's disease, that is an inflammatory disease of the small bowel. It is not due to loss of mucus. You don't see a decrease in mucus, but in ulcerative colitis, which is probably due to a loss of protective mucus in the colon, it is far lower. Phosphatidylcholine content of the mucus controls Crohn's disease. This is in the ileum, so that is the terminal aspect of the small intestine. So you're not making enough mucus in the terminal small intestine, so it's not getting into the colon. You get ulcerative colitis, and in the colon you can see it's far lower in those with ulcerative colitis. So the cells of the stomach, the cells of the small intestine generate this protective layer of mucus, and it's supposed to travel from the small intestine into the colon. And if we don't have this mucus layer, then in the GI tract, and bacteria, even normal bacteria, will attack the membrane of the colon. We're going to get ulcerative colitis. What can we do about this? 60 patients with chronic active ulcerative colitis. They had a clinical activity index above 4, none on steroid therapy. Baseline evaluation, then randomized to receive 4 times a day over 3 months, delayed release phosphatidylcholine. Now, if we take in phosphatidylcholine, it will be absorbed in the small intestine. None will get to the large intestine. If we give it to you IV, it will be picked up by the small intestine, not the large intestine. So they created a delayed release phosphatidylcholine. They formulated it in a fashion that it wasn't released until it got to the terminal small intestine, the ileum, and then it got dumped into the colon. So this is phosphatidylcholine designed to get into the colon, or placebo. Remission's defined as 3 months clinical activity index below 3 or a 50% improvement from baseline. Remission at 3 months, 10% with placebo, 53% with delayed release phosphatidylcholine. Improvements in what the colon looked like with colonoscopy, how it looked under the microscope, and quality of life. A similar study, 40 patients with chronic active ulcerative colitis, randomized to receive 4 times over 3 months, increasing doses of delayed release phosphatidylcholine. Remission at 3 months improved, and the greater the dose, the greater the degree of remission. Nobody improved with 500 milligrams. As you go from 1,000 to 3,000 to 4,000, increased remission, improvement in endoscopic activity index also improved. So quality of life, symptoms, the appearance of the colon on colonoscopy improved with this delayed release phosphatidylcholine. This material is not available in the United States, probably because it cannot be patented. It's being studied in Europe. Hopefully it'll make it to the United States. Some of you who are listening may be compounding pharmacists. If you could find a way of generating delayed release phosphatidylcholine, this would be a great value to our patients with ulcerative colitis. So we've demonstrated that PPC will blunt upper GI inflammation and ulceration related to the ingestion of non-steroidal anti-inflammatory agents. Now let's explore whether there might be a synergy between PPC and non-steroidal therapy in lowering systemic and focal inflammation. So we're going to take rats and inject one of their hind paws with Freund's adjuvant. Now this will stimulate focal autoimmune arthritis in the affected joint. 3 days later, we're going to administer via an NG tube ibuprofen, a non-steroidal agent at increasing doses, or ibuprofen chemically associated with 35% phospholipid. And I think what they did, they agitated the phospholipids and made these microspherical units that are well absorbed, kind of like what we do with EDTA in Detox Max or Lipophos EDTA. And then you put the animal in a harness and you record how much pressure can be applied to the paw before the animal withdraws or winces. Now, this is how much pressure needs to be applied to the contralateral non-instrumented paw. You have to push pretty hard to get the animal withdraw. In the joint that has the focal autoimmune arthritis, they're very, very sensitive. They will withdraw at a low level of pressure. As you increase the dose of ibuprofen, there's protection and there's a synergy with ibuprofen admixed with phosphatidylcholine. So ibuprofen admixed with phosphatidylcholine works better than ibuprofen in blunting pain in this situation of experimental inflammation involving one joint. Lewis rats are genetically susceptible to autoimmune-mediated arthritis. So if you inject Freund's adjuvant into female Lewis rats, they will develop an inflammatory polyarthritis, kind of like an experimental rheumatoid arthritis. So you create this polyarthritis. 2 weeks later, begin daily gastric treatments with ibuprofen. Ibuprofen associated with 35% linoleic acid phosphatidylcholine, a weak phospholipid, or ibuprofen associated with 90% linoleic acid. That would be similar to PPC. Periodically record pain threshold and joint thickness as a marker of inflammation. Euthanize at 6 weeks and examine the ankle joint. And what you find, pain threshold is increased with ibuprofen, particularly ibuprofen associated with phosphatidylcholine, and 90% phosphatidylcholine is more effective than 35% phosphatidylcholine. Ankle joint thickness, a marker of autoimmune inflammation, is attenuated with ibuprofen, particularly when it's associated with PPC. And again, 90% PPC does better than 35% PPC. If you aspirate the joint fluid and look at levels of inflammatory mediators, it's blocked with ibuprofen. There's a synergy when you associate the ibuprofen with the PPC. If you look at the ability of the material to inhibit cyclooxygenase, lower concentrations will be effective if you associate the ibuprofen with the phosphatidylcholine. To sort of summarize here, non-steroidals, upper GI inflammation, and PPC. Non-steroidals and aspirin inhibit cyclooxygenase, decrease in inflammatory prostaglandins, the desirable effect, less pain and fever. But they also will decrease the generation of cell maintenance and anti-inflammatory prostaglandins. Non-steroidals are associated with depletion of the phosphatidylcholine-rich mucus layer, upper GI inflammation, peptic ulcer disease. PPC supports gastric mucus production. Non-steroidals associated with PPC are more effective in dealing with pain and inflammation, need a lower dose. Non-steroidals associated with PPC are less likely to cause upper GI ulceration. They also did a study where they admixed the non-steroidals with PPC, and they were less likely to erode the upper GI tract. So if you're taking one of these agents, you ought to take PPC along with it. I take 900 milligrams 3 times a day. Now, I don't take aspirin, I don't take ibuprofen, but I'm going to take PPC because I want to lower inflammation and I want to lower oxidative stress and I want to protect cell membrane function in my body. So I'm going to take PPC, and I'm going to suggest the same for all of you. PPC in experimental atherosclerotic Parkinson's disease. What is Parkinson's disease? It is a disease of aging, although we're now seeing it in younger people, where you suffer from insufficient dopamine, a neurotransmitter in the motor center of the brain called the substantia nigra. So if you don't have enough dopamine, you have trouble controlling your muscles, you're rigid and stiff. And it's a progressive disease, and it's due to oxidative stress. Too many free radicals are damaging the neurons that make dopamine in the substantia nigra. So it's a disease of focal oxidative stress within the substantia nigra. Atherosclerosis may play a role because if you have insufficient blood supply, you're going to get oxidative stress. And toxins are a key player here. And this is why we're seeing Parkinson's disease in younger and younger people. As we become more toxic, we have more oxidative stress here in the brain, compromising the neurons that make dopamine and substantia nigra. So we're getting premature Parkinson's disease in our society. The raw material to make dopamine is tyrosine or another amino acid, phenylalanine, that's converted to dopa, then to dopamine, and then it's broken down to norepinephrine and epinephrine. And involved here, you need tetrahydrobiopterin, BH4, and SAMe. And both of those are generated by the methyl cycle. So here you can see how this is all working together. We know that PPC will help with the methyl cycle. If the methyl cycle is working, we're going to make more BH4, we're going to make more SAMe. Will PPC thus be of value in atherosclerotic Parkinson's disease? And we know that PPC lowers inflammation, it lowers oxidative stress, and it protects the cell membrane from oxidative damage. So we could theorize that PPC would be of value. So we're going to take 68 male Wistar rats and divide them into 80 or 160-day treatment groups. One group gets basic Purina rat chow. They're the normal control group. Another group gets an atherogenic diet for 80 days. This is a diet of 20% cholesterol, 40% margarine with trans fats, wheat, so you're getting gluten and inflammation, and 0.01% monothiourouracil. You're creating a hypothyroid physiology. When you're hypothyroid, you can't burn off the cholesterol. This is going to cause atherosclerosis in the rat model. Another group gets the bad diet for 80 days with increasing doses of PPC. Another group gets the bad diet for 80 days. Then you go on a good diet and you add increasing doses of PPC. Can you resolve any deleterious effects of the bad diet? So in the animals that receive the atherosclerotic diet for 80 days, those on the bad diet, they look at exploratory activity. You put the animal in a box and record its ability to move around and explore. And if you have Parkinson's disease, you'll just sit there, you won't move around. If you're healthy, you'll move around. So this is sort of an animal model index of Parkinson's disease. And you can see with the bad diet, the animals did not move around, they did not explore, and this would be the correlate to experimental Parkinson's disease. If you're on the bad diet, but you get PPC, and they called it EPL, essential phospholipid, you actually had improved motion. So the tendency of the bad diet to cause experimental Parkinson's physiology was prevented by concomitant treatment with PPC. Then the animals that were on the bad diet, then they were put on a good diet with PPC. You could see that there was also a curative effect. So PPC neutralized or resolved the adverse effects of an atherosclerotic diet on this impaired open field exploratory activity, which would be a experimental indicator of experimental Parkinson's. Brain catecholamine content. Norepinephrine and dopamine are the neurotransmitters that are made in the substantia nigra that are used to help us move. And if you have Parkinson's disease, you'll suffer from depletion of norepinephrine and dopamine, and this occurred with the atherogenic diet, and that was blunted, it was protected against with the concomitant treatment with phospholipid. If you look at norepinephrine and dopamine, they are preserved with phospholipid therapy. And if you are on the bad diet for 80 days, then you go to the good diet and you get treated with phospholipid, there's a curative effect. So what happened with these animals? Serum lipids improved. They also looked at aortic atherosclerosis that was blunted. Exploratory motor activity was enhanced. Brain catecholamine content was enhanced. And the motor activity correlated with brain catecholamine content. So if you preserve catecholamines, you'll preserve motor activity. You will not demonstrate this Parkinsonian physiology. And they hypothesized that PPC worked by preserving blood flow because we know that PPC protects against atherosclerosis. Cell membrane transport was improved, so you got the raw materials in and the dopamine out. Oxidative stress was attenuated, and we know now that PPC improves the methyl cycle function, and you need BH4 and SAMe to convert raw materials into dopamine, and PPC helps here. So in this experimental model of atherosclerotic Parkinson's disease, PPC was of value. As a cardiologist, I'm quite liberal with the recommendation that you take PPC either orally or intravenously. And when we use PPC to treat the heart and the arteries, we mix the PPC in a IV bag of dextrose and dribble it over 90 minutes. My colleagues who are integrative neurologists use the PPC in a different format that they describe as the lipid exchange. And what you do here, you have a syringe half full of PPC, you puncture the vein, draw back blood, and you agitate the syringe so the PPC will attach to the red cells, and then you infuse this slowly, and this ensures an even distribution of PPC throughout the body, and it gets into the brain. I'm interested in the heart and the arteries, they're interested in the brain. You follow this with intravenous glutathione, which is an antioxidant and detoxifier, and IV folinic acid to stimulate the methyl cycle to make more SAMe, even more glutathione. And this is used to detoxify and rejuvenate the brain. And of course, the PPC is going to absorb free radical hits. It's going to lower inflammation. It's going to repair the cell membrane. Glutathione promotes detoxification. Folinic acid for the methyl cycle. David Perlmutter is an integrative neurologist, and he's written several books, and he's popularized the use of IV glutathione in the treatment of Parkinson's disease. On his website, he'll show people with obvious Parkinson's symptoms. He gives them a single dose of IV glutathione, and they get better right on the spot. Why does that work? The glutathione will neutralize free radicals. The neurons that make dopamine will come back online. You'll make dopamine. Your Parkinsonian features will attenuate. It doesn't last. It's not curative, but it's ameliorative. A group in Italy took a number of patients with Parkinson's disease. They treated them, I think, 3 days a week for 2 months, and they did improve while they were on therapy. Well, if short-term free radical neutralization helps, will long-term antioxidant support be of value? Yes, it will. High-dose CoQ in the study that I'm quoting, they used 800 to 1200 milligrams a day, and there was a benefit. Intravenous NAD, nicotine adenine nucleotide, is a very promising therapy in the treatment of neurologic disease and all age-related degenerative disease states. When we administer IV NAD, we promote mitochondrial biogenesis. You make more mitochondria. You are more adept at generating ATP energy from the sugar and fat that you ingest. When we're young and healthy and full of vim and vigor and energy, we have lots of mitochondria in our cells. As we age, as a result of oxidative inflammatory stress, the mitochondria drop out. We're not able to generate energy. We don't have that vim and vigor of youth. If we give you IV NAD, we should generate more mitochondria. Energy generation comes back online. The more energy that we can make, the better able we are going to be to repair damaged structures within our cells. The psychiatrists are several decades out in front of us in the use of IV NAD. They view psychiatric disease not as being crazy, but as a result of a biochemical imbalance in the brain, not enough energy. So they will treat you with IV NAD, and many people get better. Schizophrenics may get better with IV NAD. Detoxification from recreational and prescription drug abuse is enhanced with NAD. If you go cold turkey with these drugs, you go into withdrawal. But if they treat you with IV NAD, that prevents the withdrawal. And there are clinics that will help you detoxify from cocaine and Ritalin and opiates with IV NAD. There's a psychiatrist who has a great deal of experience with IV NAD who's mentoring me, and I'm going to learn all about it because in animal models, IV NAD is of value not just in psychiatric and neurologic disease, but in heart failure. So if you have heart failure and we treat you with IV NAD, we should provide some benefits. So this is something that I'm going to learn a lot about, something else, another tool that we can look forward to utilizing. Phosphatidylcholine in experimental brain acetylcholine deficiency. Alzheimer's disease is characterized by the absence or lower levels of acetylcholine, that is the neurotransmitter that's involved in generating and maintaining memory. So what we're going to do, we're going to look at memory acquisition and execution of stored memory in young mice. Normal mice and genetically abnormal mice, we're going to call them dull mice. They're genetically deficient in acetylcholine, low brain acetylcholine, and they also suffer from deficiencies in other neurotransmitter substances such as serotonin and norepinephrine. 85% of these dull mice will display impaired memory. So we're going to carry a dietary intervention, mating through 10 weeks of life. So at the time of conception, the moms are put on a specific diet, and the pups after they're born are put on a specific diet. There's the standard 24% casein diet, which would be like Purina mouse chow, or 24% casein diet supplemented with 2% or 8% phosphatidylcholine. They did not use PPC, they used egg yolk derived phosphatidylcholine, and it only had 12% linoleic acid. What we use is 80 to 90% linoleic acid. They just used phosphatidylcholine derived from egg yolk. And you're going to evaluate memory at 10 weeks of age. And your experimental model will be passive avoidance of foot shock. So you'll put the animals in a box on a raised disc like a hockey puck. They don't like that. They feel disequilibrium. They want to hop down to the ground. But if they hop down to the ground before 180 seconds has elapsed, they get a shock. They hop back up on the disc. So they're going to keep doing this over and over again. And eventually they're going to learn, they're going to develop a memory that if you hop onto the ground before 180 seconds, you're going to get a shock. So the smart mice that are able to learn from their experience will not hop onto the ground until 180 seconds has elapsed. So you'll look at the number of trials before the mice learned to avoid the shock. So in these normal mice, 10% of them got it right with one try, 40% with two, 80% with three. And if you treat them with PC, nothing happens. They're already normal. They can learn normally. The dull mice that have low levels of acetylcholine, they take many more trials before they learn not to hop off the disc early and get the shock. But if you treat them with phosphatidylcholine, which provides choline to help you make acetylcholine, the dull mice sharpen up a little bit and they learn to avoid the shock. So memory and execution of memory is enhanced. They repeated this experiment where they began the dietary supplementation at 4 weeks of life. In the normal mice, there was no benefit. In the dull mice, they learned better and they were able to avoid the shock more readily. So in this experimental model of impaired memory due to low brain acetylcholine, supplementation with phosphatidylcholine was evaluated. So memory acquisition and retention, in normal mice, phosphatidylcholine had no benefit because you're already normal. Memory acquisition and retention was impaired in the dull mice that had low levels of acetylcholine, and memory acquisition and retention improved in the dull mice with prenatal and postnatal phosphatidylcholine supplementation. Phosphatidylcholine effect in explicit memory. 80 college students, and you're going to assess explicit memory. Now, when I was a freshman in college, I was a psych major. I later switched to chemistry when I determined I wanted to be a doctor. But I took a lot of psych classes, and for extra credit, you could be a guinea pig in these research projects that the psych grad students were carrying out. So I would be involved in a study kind of like this. And what they would do, you'd sit in a room, and they would present 8 3-word nonsense syllables on a slide projector. 5 seconds per syllable, 2 seconds between the slides. Then afterwards, you were asked to write down the syllables in correct order after all 8 were presented. So this is an assessment of your short-term memory. And you record the number of trials needed to achieve correct sequences and content. And then you were randomized to receive phosphatidylcholine made by the Twin Labs company, which it was 55% phosphatidylcholine and other phospholipids. And this would provide either 10 or 25 grams of choline. The idea is the choline goes into acetylcholine, your memory should improve. You get the phosphatidylcholine supplement or matching placebo, memory assessment at 60 to 90 minutes, double-blind protocol followed. So what did they find here? The low-dose phosphatidylcholine to provide 10 grams of choline had no effect on the number of trials needed to achieve correct sequencing at 60 or 90 minutes. However, the high-dose phosphatidylcholine did have an effect, particularly at 90 minutes. And they found that the benefit of phosphatidylcholine was best in individuals who were slow learners. So if it took a greater number of trials to get it right with placebo, you got a better kick with phosphatidylcholine. And this is probably similar to the benefits of phosphatidylcholine in dull mice, but not in normal mice. Individuals who are great learners probably have a lot of acetylcholine. Giving them extra choline is not going to help. But the students that might have suffered from lower levels of brain acetylcholine got the greater kick. So in any event, phosphatidylcholine does have a benefit in memory. Why would this work? Well, phosphatidylcholine improves cell membrane function. You're going to get raw materials in, you're going to get neurotransmitters out. And in addition, to make neurotransmitters, you need BH4, you need SAMe. Those are products of the methyl cycle. We can support the methyl cycle with phosphatidylcholine. So it is biochemically logical that phosphatidylcholine would improve memory because it's going to improve brain function and improve the generation of acetylcholine within the brain. Obviously, good memory and great brain function is important to all of us. What can I do to help within my role as an integrative cardiologist? Well, first of all, I can modify your pharmaceutical program. Many of the drugs that we use to treat cardiovascular disease will have a negative effect on memory and neurologic function. The chief offender, of course, are the statin drugs that block the generation of cholesterol. Most of you who take statins can take them and you don't notice a side effect, but some of you note that it dulls you, particularly those of you who are my age or older, who are professional people. If you make your living thinking, you note that there's some sluggishness. So what can we do? Well, first of all, I can substitute a nutraceutical statin for a pharmaceutical statin because it's typically not the reduction in cholesterol that's compromising your memory, it's the statin drug itself. We know that statins deplete coenzyme Q, so we'll supplement with coenzyme Q. If you're a man and I put you on a statin, I'm going to lower your testosterone level. With low testosterone, your brain doesn't work very well, so if I need to leave you on a statin, I can treat you with testosterone. So I can modify your pharmaceutical program to still obtain a beneficial cardiovascular outcome without compromising your mind. Well, we've been talking about the role of PPC in improving memory. PPC improves cell membrane function. PPC is of value in neurologic disease. We would anticipate that PPC would be good for our brains and prevent cognitive decline associated with aging, which is why I'm taking 900 milligrams 3 times a day. And I take many more other supplements that I've learned about that are good for my brain because I want my brain to remain sharp and crisp even though I'm going to age. And we can use PPC intravenously. And when our focus is on neurologic disease and not cardiovascular disease, we'll use the IV PPC within the lipid exchange, following it with IV glutathione and folinic acid. Relapse stroke recovery is a unique and effective approach to improving your functional status following an ischemic stroke. Now, I'm participating in the relapse research. I've signed a confidentiality agreement, which I'm going to honor, so I can't tell you exactly what we do with relapse. The inventor of relapse, Dr. Bruce Rinn, discusses relapse on his website, so I'm going to refer you to drrinn.com, drrind.com. Basically, with relapse, we wish to jumpstart metabolic recovery within the ischemic penumbra. What's the ischemic penumbra? So you've had a stroke because a blood vessel closed, you've lost some cells. Those cells are dead, they're not coming back. You have the normal brain, but then there's a rim of tissue surrounding the zone of cellular death called the ischemic penumbra. Those cells didn't die, but to prevent themselves from being damaged and dying, they went into a state of hibernation where they didn't need much oxygen or energy. But they don't die, but they never recover function. So part of your deficit following a stroke is the ischemic penumbra not coming back to life. So with relapse, we jumpstart metabolic activity within the ischemic penumbra. And when we treat you and it works, you note a benefit by the end of that day. And we're using molecules that are in the refrigerator in my office that I use every day in my practice as an integrative cardiologist. Within relapse, we use specific molecules and administer them in a specific sequence in a specific fashion, and that's really the magic of relapse. Now, the people behind relapse are not big pharma people, they're not medical people, they were patients. These were individuals who were very successful in their careers and who got sick. And they had Lyme disease, basically, and they saw the leading physicians in their communities who really weren't able to help them, and it was suggested to them, well, they're just depressed, you're just crazy. So they wouldn't accept that, so they sought input from integrative practitioners, and these people have the means to go all around the United States and see integrative practitioners, and they've got to know me because if they have cardiac problems, they come to me. They went to Dr. Rind for their Lyme disease, and they noticed that people in the practice were being treated with Relox for stroke recovery. They become fascinated. They decided to form an organization to promote Relox, and they put $3 million into it to fund this study. And we participated, as did 3 other integrative medicine practices. And it was a double-blind study. I know what Relox is, and I'm administering the Relox to you, so I wasn't blinded, but you were. You didn't know what to expect. You didn't know if you were getting Relox or a placebo. The nurses that evaluated outcomes didn't know. So this was a properly designed, randomized, double-blind study. And the chief researcher took the results to the FDA, and the FDA accepted it, that it worked. We actually improved functional status in individuals who were 6 months out, assumably fully recovered from stroke. And then the FDA said, well, we don't know that this is still not a placebo effect. Do a bigger study that's going to cost $35 million. The people behind it aren't going to get $35 million back from their investment, so we're kind of stuck right now. But hopefully, we'll get some money together, and then we can complete the research, and this will be put in everybody's hands. So Relox stroke recovery is a great idea that I can talk to you as an individual about it, but I just can't tell you as a group what it's all about. But you can go to Dr. Rind's website. Magnetic molecular energizer therapy. We used this for about 15 years. The Institutional Review Board, which provides us the regulatory authority to use MME, has expired, so we no longer are able to use it. And the problem here was not enough support, not enough money, thus the IRB was discontinued. But the MME machine is a 10,000-pound electromagnet. We will beam a static magnetic field through your brain, your liver, your bones, your kidneys, whatever organ we want to treat, and it's going to cause electrons to orbit the nucleus of every atom in the region we're treating. We're basically transducing electrical energy into biochemical energy. With that increased ATP biochemical energy, the cells repair, the organs repair, and we can do some really wonderful things with this. If you break your leg, and it's going to heal up in 2 months. With MME, it's going to heal up in 2 weeks. So we could treat organs that are damaged or dysfunctional and enhance healing. In situ stem cells proliferate when exposed to a static magnetic field. So we used it for brain function and stroke recovery. And we help people with stroke recovery. We help kids with autism. We help kids with cerebral palsy. And it's a shame that the IRB was elapsed. It's a shame we didn't get more support, because this is a wonderful therapy that hopefully will come back online in the future. Well, if those therapies are not effective, or if we can't use them because the regulatory authority has elapsed, we will then turn to globus pallidus cadaver grafting. And we just call this the partial brain transplant procedure because it's easier to say. Now, Dr. Poling got involved with this 20 years ago when he got me involved. And we're on the list of donors, so to speak, because if you're on the donor list, you can benefit from this therapy, or perhaps your family members can. So what we're going to do, we're going to try to die, when we die, at the right place and the right time, and we're going to be flash frozen. Our brains will be removed and cryopreserved. And then if somebody needs the globus pallidus, the brain will be thawed. You remove the globus pallidus. Now, this is a endocrine hormone-rich, growth factor-rich region of the brain. And if you graft it into your brain, the growth factors will stimulate cellular regeneration in your own brain. So it's really kind of a growth factor therapy, taking the globus pallidus from a flash frozen donor brain. So the brains are kept in this sort of suspended animation, cryopreservation situation before they're going to be used for the partial brain transplant. So if you're interested in this, and you have to be my patient or Dr. Poling's patient, there's a dozen doctors in the United States that are involved. What we have to do, we go with you to Mexico. This is such a big deal that we are going to go with you to Mexico. And the first thing you need to do is decide what type of brain you want to get the globus pallidus from. So there's this room, and all the brains are in these little suspended animation chambers. We pick out a brain, and there's a guy there who organizes it. We call him the brain salesman. So first you got to pick out a brain. Now, if you want to get the brain of a university professor, it's $20,000. High school teachers, a little bit less. Gardener, $16,000. Integrative cardiologist like me, a Robert's brain is $30,000. A brain of an integrative osteopathic doctor like Dr. Poling is $25,000. You can see that my brain costs a little bit more than Dr. Poling's brain would. An invasive cardiologist, the way I used to practice when I was younger, is $80,000. Heart surgeons, $100,000. Hospital administrators, $140,000. U.S. congressman or a senator is $180,000. And an insurance company executive is $200,000. So you have to pick out the brain, and the brain salesman says, well, which do you want? You could do the cardiovascular surgeon, the congressman, or even better, the insurance company executive. And you might say, gee, I understand that it takes a lot of brain power to be a heart surgeon or a congressman or to run an insurance company, but why can't I get one of the less expensive brains, the university professor or the integrative cardiologist? And how come those brains don't cost as much? And the guy will say, well, you don't want those brains. They're less expensive because those brains, they're used. You want another brain. Now, we need your brain to be working well to help us understand TMAO, trimethylamine N oxide. Now, this is an area that is being researched intently. Our body of knowledge is not elaborate, but it serves as a potential downside, at least a theoretical downside of supplementation with PPC, so it's something that we need to examine. Dr. Poling, my colleague, has been involved in this for a couple of years, and he's been talking to me about it, and we're collaborating to figure out what's the best approach to lower TMAO in our patients. TMAO is very interesting because your TMAO level relates to an interaction between specific foodstuffs, the status of the flora, the microbial flora in your GI tract, the status of detoxification enzymes in your system. So in theory, PPC can harm us here. It probably won't, but we're going to examine this. And most integrative physicians will say all disease begins in the gut. And if we look at the link between TMAO and cardiovascular disease, we can say cardiovascular disease begins in the gut. So it is appropriate for me to evaluate your GI tract and optimize GI tract function because I need to lower TMAO to protect you from cardiovascular disease. So what happens here is that foodstuffs that provide choline, such as phosphatidylcholine that we would get from supplements or from eggs or from meat, carnitine can be converted into choline, will be converted by specific bacteria in the gut to a molecule called TMA. TMA is absorbed, and in the liver, an enzyme called flavin monooxidase 3 will convert it to TMAO, which is a pro-oxidant, pro-inflammatory substance. So looking at this again, if we take in carnitine from red meat, phosphatidylcholine, now the studies didn't involve PPC, the studies involved food sources of phosphatidylcholine, such as eggs and meat. And of course, that phosphatidylcholine would be enriched in saturated fatty acids, not linoleic acid like PPC. So these molecules that are converted to choline will be converted by specific gut microbes into a molecule called TMA. TMA is absorbed in the liver. Flavin monooxidase 3 converts to TMAO. TMAO is a pro-oxidant, it is pro-inflammatory, and thus you won't be surprised to know that it's associated with an increased risk of cardiovascular disease. The greater your level, the more likely you are to get into trouble. It's also associated with an increased risk of kidney disease, it's an increased risk of diabetes, an increased risk of obesity. And of course, you're not surprised because anything that causes oxidative inflammatory stress will cause all these conditions. TMAO will interfere with cholesterol metabolism. It promotes foam cell formation. It actually increases elaboration of scavenger receptors in your white cells that will engulf oxidized LDL and begin to form foam cells, which is the initial sign of atherosclerotic plaque. Reverse cholesterol transport, which we're stimulating with PPC, is compromised by TMAO. TMAO is clearly a bad actor. So we have foodstuffs that are converted by GI tract microbes into TMA, that TMA is converted into TMAO in the liver. So let's examine this a little more closely. Well, carnitine we get from red meat. So I guess we could all agree that red meat's not really good for us, but we also use carnitine as a nutritional supplement. Many of you are taking carnitine upon my recommendation because we know that carnitine is of value in ameliorating symptoms and decreasing mortality and heart attack rate in individuals with angina, heart failure, particularly cardiomyopathy. It decreases your risk of dying after a heart attack. So if it decreases your risk of dying of cardiovascular disease, but it also makes TMAO, that's kind of inconsistent. That doesn't make a lot of sense. Choline we get from phosphatidylcholine from eggs and meat. Fish contains choline, and fish also contains TMA. So if you take in fish, your TMAO level is going to spike. Well, wait a minute, but fish is good for us. Well, we understand that fish has mercury, but the mercury in fish has nothing to do with this biology. Fish contains TMA and TMAO. Fish should be good for us, but under this theory, we would say that fish is bad. Ergothioneine, I don't think I'm pronouncing that correctly, we get that from mushrooms, can also funnel into TMA and TMAO. So a lot of these foodstuffs that we would think are good for us, at least under certain conditions, form into TMA and then TMAO being bad for us. So let's examine this. Foodstuffs are converted by anaerobic bacteria in the gut to TMA that is converted to TMAO by hepatic, that's liver-derived, flavin monooxidase 3. So what are the food and supplement-derived molecules? Phosphatidylcholine, not PPC. No one studied PPC that we use in the formation of TMAO. Presumably the PPC that we're taking could go into TMAO, but in the research they used meat and eggs as a source of phosphatidylcholine. And of course this will be phosphatidylcholine with saturated fatty acids, not unsaturated fatty acids. Carnitine from red meat. You can do a carnitine challenge study. You can take a steak, you can have eggs, you can take phosphatidylcholine, you measure TMAO before and afterwards. If you take in these foods or if you take in fish, you'll see a spike in TMAO. Fish is a raw material, and it also contains preformed TMA and TMAO. Mushrooms have ergothioneine. So these are foodstuffs that are processed by anaerobic bacteria into TMA, which is then metabolized further into the pro-oxidant, pro-inflammatory marker TMAO. The foodstuffs alone are not the problem. The foodstuffs must be converted by anaerobic bacteria in the gut into TMA that is then converted to TMAO. So the content of the bacteria in our GI tract are critical in determining TMAO. Of course, all of us have different populations of bacteria in our GI tract, which relates primarily to our diet. Bacteria in the genera Bacteroides and Methanobacter cannot convert TMA to TMAO. Bacteria within the group called Firmicutes can. So if you have high Firmicutes and low Bacteroides, you are going to be a TMAO generator. We can do a comprehensive digestive stool analysis and quantitate the microbes in your GI tract. And those of you that have more Firmicutes than Bacteroides, you're going to be a TMAO generator. TMAO does not form in vegetarians. If you're a vegetarian, and I'm a 95% vegetarian, I'm a lacto-ovo vegetarian, our daughter, the hepatologist, convinced me that this is a good idea for my own personal health. So I'm going to listen to my daughter, and I'm following a 95% lacto-ovo vegetarian diet. And that is conditioning my flora such that I have more Firmicutes and less Bacteroides. So you can do a challenge study where you take someone and measure their TMAO level, you give them a steak, or you give them some eggs, or you give them a foodstuff that can be converted to TMA, and in vegetarians, nothing happens. You're eating a source of TMAO, but you're not converting it to TMA because you have a different bacterial flora. So this is how diet influences cardiovascular. One of the mechanisms through which diet influences cardiovascular health. Now, a high protein, high fat diet promotes a gut flora that is good at generating TMA. So the Western diet, one of the reasons it's hurting us is it's making us into TMAO generators. Now, antibiotics will wipe out TMA generation. If you take a broad spectrum antibiotic, you will stop making TMA, you will not make TMAO, and this will last for several weeks. But 4 weeks out, you're back in the TMAO generating business. Now, this brings up the idea of using antibiotics to treat cardiovascular disease. 20 years ago, we got excited about the use of antibiotics because protein and DNA of bacteria could be found in atherosclerotic plaque. Now, these bacteria are not live, they're dead. These are bacteria that were picked up by mononuclear cells elsewhere in your body. They entered the circulation, they were drawn into an inflamed plaque, and they participate in the immune dysregulation that characterizes atherosclerosis. They're not really there growing. So coronary disease is not really an infection. But studies were done of antibiotics. And in some of the studies, it was helpful. In other studies, it was not helpful. And the concept kind of, we lost interest in it. But I've had patients with coronary disease and heart failure who received an antibiotic because they have an infection and they got better. Now, I understand that in heart failure, we have leaky gut and bacteria in our bloodstream, so antibiotics would help. One of my patients with chronic kidney disease got an antibiotic, and he got better. His heart got better. His angina got better. And he was probably making a lot of TMAO, and it's cleared via the kidney, so it was hanging around because of his kidney disease, and the antibiotic helped. So broad-spectrum antibiotics will help, but of course, if you take broad-spectrum antibiotics, that will derange your gut flora. There's a lot of negatives there, so that's not really an effective therapy. However, nutraceutical agents such as berberine or garlic probably help here. Rifaximin is an antibiotic that is not absorbed. It works only in the small intestine. We use it to treat SIBO, small intestinal bacterial overgrowth. It probably will be useful in blocking the generation of TMA and TMAO. That has not yet been studied. Bioflavonoids, chief amongst these is the compound resveratrol, will blunt conversion of these foodstuffs into TMA. Now, there's been a lot of interest in resveratrol as a health-promoting antioxidant supplement, and I looked into the research, and I was kind of discouraged because very little gets absorbed. So if it doesn't get absorbed from the gut, how can it be helpful? Well, it's blocking the generation of TMA. So I'm taking resveratrol now because it's going to help my gut function better, and I'm going to make less TMAO. Cruciferous vegetables called brassicaceae, I don't think I'm saying that correctly, but cruciferous vegetables will blunt TMA intake, TMA generation. So if you don't want to be a vegetarian, you want to be an omnivore, take in cruciferous vegetables. Every night I have broccoli because I know that's a good idea. Now, TMAO levels may rise after bariatric surgery, weight loss surgery, probably because it's influencing your flora. You'd think that probiotics would be a good idea, but so far in the studies, it has not been helpful. Now, it may be that they didn't use the right probiotics, but so far, probiotic supplementation has not helped. There's a molecule called DMB that has it's a horrible name that you can't pronounce. We're going to call it DMB, will blunt the generation of TMA from the raw material foodstuffs. That's found in balsamic vinegar, red wine, grapeseed oil, and extra virgin olive oil, so they will help us here. So we take in the foodstuffs, certain bacteria will convert them to TMA, and then they go to the liver, and hepatic flavin monooxidase 3 converts to TMAO. So the status of this enzyme will determine whether you are or not a TMAO generator. Now, this enzyme is upregulated by estradiol and downregulated by testosterone. So if you castrate a male animal, their TMAO levels will rise. If you treat with the testosterone, it will fall. It's upregulated by estradiol. Now, this may be oral estradiol as opposed to pellet or topical. None of us who are involved in the practice of integrative medicine would recommend taking an oral estrogen, oral testosterone, even if it's bioidentical, because as they go through the liver, they induce specific enzymes. So one of the reasons oral estrogens increased your cardiovascular risk was because it was upregulating this enzyme, thus you're more likely to convert foodstuffs into TMAO. TMAO levels will rise and fall in relation to a woman's menstrual cycle. Now, TMAO has an unusual odor, kind of a fishy odor, and it is hypothesized that TMAO is a reverse pheromone. Now, pheromones are chemicals that are generated by men and women that increase sexual attraction. Now, in modern societies, we all agree that it's best to participate in a monogamous relationship and have a family. That's best for you as an individual. It's best for the future of our society. And our superegos will govern our behavior, so we enter in long-term monogamous relationships. But from the point of view of evolution, our job is to reproduce. So once we reach the age of sexual maturity, we're supposed to reproduce to propagate the species before we might get eaten by a saber-toothed tiger. And so our bodies will make these sexual chemoattractants called pheromones that will increase the likelihood that in a couple will get together. And apparently TMAO is a reverse pheromone, because if it's released during the menstrual cycle, then you'd be less likely to have a sexual relationship during the menstrual cycle, because that wouldn't be productive. You can't conceive a child. So it might be that this is one of its roles in evolution, which is kind of interesting. But in any event, if you are a man and your testosterone level is low, and we replace testosterone, we're going to downregulate FMO3. And one of the reasons testosterone is going to help you is we'll blunt TMAO conversion. Now, here's where it gets very important and interesting. Toxins will upregulate FMO3. Arsenic, and this study was done in pregnant women, so we don't want to be making TMAO during pregnancy. Organic pollutants, Agent Orange, dioxin, PCBs, will dramatically upregulate FMO3. We live in a toxic world. All of us bear these toxins. So because of this toxicity, we're more likely to convert otherwise beneficial foodstuffs into toxins. Of course, there's strategies to remove organic pollutants and to remove heavy metals, and this is something that I talk about to my patients, and we have different presentations on the website. How do we get rid of metals? How do we get rid of organic pollutants? When we metabolize cholesterol in the liver, we generate bile acids that are used to help absorb fat-soluble vitamins and to absorb fatty materials. And there's a drug that we don't use much anymore called cholestyramine. It will bind up and remove bile acids. If we don't have bile acids, the liver will convert cholesterol into bile acids. So this is a way of lowering cholesterol. And it was used extensively 20, 30, 40 years ago. Now, it will work. It improves outcome. People do better with it, but it doesn't lower cholesterol as much as do the statins. So it sort of fell into disuse. But it did help people. So one of the reasons it was helping you was it binds up the bile acids. Therefore, you're no longer upregulating FMO3. You're no longer making TMAO. So one therapy we might bring back will be cholestyramine if you have a high TMAO. Now, antibiotics will block TMA generation, so we could use berberine and garlic, and those haven't been specifically studied, at least to my knowledge, but I think people are looking into them. Probably some of the benefits of berberine and garlic have to do with blunting TMAO. Pistachio intake. If you eat pistachio nuts, it lowers TMAO. I don't know exactly at what level it works, but it's helpful. Melodium is a drug that is used in Russia to treat cardiovascular disease. And we learned about melodium because Maria Sharapova, a Russian tennis star, was stripped of a title because in her blood tests, they detected melodium, and they said she was using it for performance enhancement because apparently it does enhance athletic performance. She said she was using it for mitral valve prolapse, so there was a big brouhaha about that. But anyways, melodium is commonly used in Russia, and one of the reasons it works might be lowering TMAO. I have to study this. There's another herbal therapy, and I don't think I'm going to pronounce this correctly. It's called Gynosperma pentaphylium. It is used in China to treat diabetes and obesity and cardiovascular disease, and it blocks the generation of TMA, thus it would lower TMAO. It's available online. It's $15. And there's probably a lot of benefit here, and it's something that I need to study. Now, FMO3 is a bad guy because it makes TMAO. When it's upregulated, it does a number of other things that promote atherosclerosis. So this may be a link between toxicity and cardiovascular disease above and beyond TMAO. TMAO is excreted via the kidneys. So if you have kidney dysfunction, you're going to have greater levels of TMAO. TMAO is associated with an increased risk of kidney disease, and if you have kidney disease, TMAO will rise. There's a drug that we use to treat hypertension and heart failure called enalapril, and it stimulates excretion of TMAO. It's an ACE inhibitor, an angiotensin converting enzyme inhibitor. We don't know if the other ACE inhibitors will do the same thing, but enalapril will. Elevated TMAO is a consequence and a cause of kidney disease. And in addition, TMAO causes oxidative inflammatory stress. So if you have high TMAO and you're taking antioxidant, anti-inflammatory substances, you will mitigate the risk associated with TMAO. Again, it's all about a balance. If you have pro-oxidants, we will intervene with antioxidant substances, and this has been shown in animal models to negate the toxicity associated with high TMAO. So what are we going to do? We can measure TMAO. The lab will give us the TMAO level. Dietary intervention, become a vegetarian. It's a really good idea. Now, in some people who are overweight diabetics, we might recommend a paleo diet, a low sugar diet, but for the rest of us, a vegetarian diet is a good idea. My daughter, the hepatologist, convinced me that this is a good idea. There's some presentations you can see on Netflix. The China study and forks over knives are very convincing why we should become vegetarians. It's good for our personal health, and it increases the likelihood that our kids and grandkids will live long and healthy lives. It is very inefficient to obtain energy from animals. It is 60 times less efficient than obtaining the energy from plants. We're burning down the rainforest so we can grow crops, not to feed humans, but to feed the animals that we're going to eat. The price of food is rising around the world, and we're going to have unrest in the third world because the price of food is too high, because the crops that should be used to feed humans are being used to feed animals so we in the West can eat them. This is a dumb idea. There's a lot of global warming because we're burning down the forests, we're burning down the rainforests, so we're all going to be better off if we adopt a vegetarian diet, or at least cut back. So if you want to be an omnivore, if you don't want to be a vegetarian, at least cut back on red meat and increase cruciferous vegetables. Red wine, extra virgin olive oil, balsamic vinegar will help. Let's optimize your GI tract. We can do a comprehensive digestive stool analysis, look at the mixture of bacteria in there, intervene to promote digestion, get the right flora so you're less likely to make TMAO. Bioflavonoids, which resveratrol, red wine, garlic, and berberine are probably helpful. We're going to get rid of organic pollutants and arsenic, and there's probably a role for supplementation with pistachio and the gynostemma pentaphylium, which I'm going to have to study. Ancillary measures optimize kidney function, and of course, we can neutralize the pro-oxidant and pro-inflammatory effects of TMAO with antioxidant and anti-inflammatory supports. Phosphatidylcholine provides powerful antioxidant and anti-inflammatory effects. Phosphatidylcholine stabilizes our cell membranes. Phosphatidylcholine will protect our cells from various insults. Will phosphatidylcholine thus be of value in the prevention of malignancy? Let's start with a cell culture study. The researchers took 4 different human hepatic cancer cell lines. These are malignant cells that are essentially immortal. They will live forever in tissue culture. They are used in research to evaluate the effects of new therapeutic agents. If a new drug will inhibit the growth of these immortalized human cancer cells, then that agent will be a candidate for therapeutic use in humans. So we're going to take these immortalized cancer cells and incubate them with soybean-derived phosphatidylcholine, vitamin K2, combination therapy, or vehicle, a placebo substance. Now, the researchers didn't say exactly what the linoleic content was of the phosphatidylcholine. I don't think it was the 85% linoleic acid that we use. I think it was more like a 60%, but it's still soybean-derived phosphatidylcholine rich in unsaturated fatty acids. Vitamin K2 is discussed in greater detail elsewhere in the heartfix.com website, but basically the job of vitamin K2 is to protect against vascular and valvular calcification. Humans who take in above average levels of vitamin K2 in their diet enjoy relative protection against atherosclerosis, particularly calcific atherosclerosis. We get K2 from meat and cheese if the animals eat grass. If the animals are force-fed soybean and corn, they have no K2. Americans in general are K2 deficient. Thus, K2 supplementation is a general recommendation that I give everybody, particularly if you have known vascular calcification. So the experimental treatment was phosphatidylcholine, K2, combination therapy, or neither. You're going to evaluate the degree of growth inhibition. Will these substances actually kill the cancer cells and we look at the degree of apoptosis. Apoptosis is cellular suicide. We want our immune system or a therapeutic substance to convince these cells to commit suicide and die. Now, we're going to see that phosphatidylcholine in a dose and time-dependent fashion killed the cancer cells. As you increase the dose of phosphatidylcholine in all 4 of the cell lines, you see reduced cancer cell viability in a dose and time-related fashion. Now, if we increase K2, we also see a decrease in cancer cell viability. So phosphatidylcholine works, vitamin K2 works in inhibiting the growth of these cancer cells. Here, we're going to increase the concentration of phosphatidylcholine upon a fixed dose of K2. And we can see the more phosphatidylcholine that we apply, the greater will be the ability of the phosphatidylcholine K2 combination to kill the cancer cells. Cancer cell apoptosis is convincing the cell to commit suicide. And as we increase the concentration of phosphatidylcholine, we see greater cancer cell apoptosis, cellular suicide. Here we can look at the ability of the vitamin K to inhibit the growth of the cells. If you add in phosphatidylcholine to the vitamin K, you get a greater degree of growth inhibition. Phosphatidylcholine was helpful, vitamin K2 was helpful, and there was a synergy between these 2 nutraceutical substances. Now let's look at an animal model. We're going to take 4-week-old genetically normal Sprague-Dawley rats and divide them into 8 experimental groups. The first group is exposed to a carcinogen at 4 weeks. This is a carcinogen DEN, and then at 6 weeks, they're treated with phenobarbital. Phenobarbital is a barbiturate. It's used in the treatment of epilepsy. We don't use it much anymore because when you take phenobarbital, it increases the activity of several detoxification enzymes in your liver, and as it detoxifies the phenobarbital, it creates a great deal of oxidative stress. So this is a model to induce malignancy in animals. Carcinogen exposure along with phenobarbital to create oxidative stress. One group received the carcinogen and the phenobarbital with phosphatidylcholine supplementation. Another group gets the 2-hit induction of malignancy, the carcinogen and phenobarbital, and they get phosphatidylcholine and K2. Another group gets the carcinogen without phenobarbital. Another group gets the carcinogen with K2 plus phosphatidylcholine. Another group is treated simply with the nutritional substances, vitamin K2 and phosphatidylcholine. You're going to sacrifice all the animals at 20 weeks and evaluate the liver. So you're going to look at the number of nodules on the liver. That's a tumor on the liver, and this is what it looks like under the microscope. This is the tumor region, and then there's sort of a wall of fibrous tissue between the malignant region and the normal liver cells. So phosphatidylcholine and vitamin K2 are not carcinogenic. They did not cause any liver nodules to be generated. If you get the carcinogen and phenobarbital, you get a lot of liver nodules. And there is protection with phosphatidylcholine, and there's synergistic protection against carcinogenesis if you utilize phosphatidylcholine and vitamin K2. Cancer cell apoptosis, control cells are not, there's no cancer, there's no apoptosis. If you expose them to the carcinogen, there's no apoptosis because the cells are growing, they're not committing suicide. But if you expose the cells to the carcinogenic stimuli and treat them with phosphatidylcholine, you can see that they begin to commit suicide. So phosphatidylcholine and K2 are inhibiting the growth of cancer cells, they're killing cancer cells, and they're stimulating these cancer cells to commit suicide, apoptosis, which is what you would want if you don't want to have a malignancy or if you want the malignancy to regress. Let's examine the effect of aging on the lipid content of our cell membranes. We're going to take 86 grossly normal human aortas, and we see that early in life, we have a large representation of phosphatidylcholine in the cell membrane. Thus, it's fluid and elastic and healthy. As we age, phosphatidylcholine drops out, triglyceride increases. Free cholesterol falls, cholesterol ester increases. So we're abnormally esterifying our cholesterol within the cell membrane with oleic acid. Here, we're going to look at cell membrane lipid content of heart cell reaggregates in newborn, 3-month, and 18-month-old rats. So a 3-month rat would be like a young adult human. An 18-month-old rat would be an aging human. What they did, they removed the hearts, they diced them up, put them in a tissue culture. The cells will reaggregate and begin to beat. And we can look at the lipid content of the cell membranes and see what effect aging has. So you see that over time, there's an increase in total phospholipids, not just phosphatidylcholine, but all phospholipids, phosphatidylcholine, phosphatidylserine, sphingomyelin, phosphoethanolamine, and there's also an increase in cholesterol. But the rate of increase in cholesterol outpaces that of phospholipid, so as these cells are aging, newborn, young adult, older adult rat, the ratio of cholesterol to phospholipid increases. With aging, phosphatidylcholine representation of the cell membrane declines. Phosphatidylethanolamin is pretty much static. Sphingomyelin increases. Now, sphingomyelin is a phospholipid just like phosphatidylcholine, but its fatty acids are saturated. Thus, the cell membrane containing sphingomyelin will be more rigid and stiff. It will be less fluid than if the cell membrane contains a lot of phosphatidylcholine with the unsaturated fatty acids that can't be packed closely together. The phosphatidylcholine to sphingomyelin ratio declines with aging. CPK is creatine phosphokinase. It is an intracellular enzyme involved in energy generation. You find this in muscle cells. And with aging, the CPK content of our cells increases. CPK is found in association with membranes, and it's felt that as membrane function decreases, CPK activity falters, thus we make more CPK. But in any event, CPK levels rise with aging of our cells. And as you go from newborn, young adult to older rat, the CPK content increases. Now, we're going to add to these heart cell reaggregates liposomal phosphatidylcholine. This is very similar to the Detox Max or lipophosphatidylcholine supplement that we use clinically. So let's look at total phospholipids. There's an increase over time from newborn, young adult, and older rats. If you add in phosphatidylcholine in these liposomes, you can see that the phosphatidylcholine content will increase, particularly in the older rats. Cholesterol will increase with age, but if you flood the cell membrane with phosphatidylcholine, cholesterol representation falls. So we're going to increase phosphatidylcholine representation. Conversely, we're going to decrease cholesterol representation. So the cholesterol to phospholipid ratio will fall in the newborn mice, in the 3-month-old rats, and particularly in the older rats, the cholesterol to phospholipid ratio will fall. It'll be even lower than in the newborn rats. So you'd think that that would improve cell membrane function, because the more phosphatidylcholine, the less cholesterol, the less triglyceride, the less sphingomyelin, the more functional will be our cell membranes. Percent phospholipid composition. So here we have the untreated newborn, 3-month, and 18-month-old rats. If we add in phosphatidylcholine, we see there's a decrease in sphingomyelin, where we're displacing sphingomyelin with phosphatidylcholine. We see a reduction in phosphatidylcholine content with age in the rats, and that is reversed if we add in phosphatidylcholine. The phosphatidylcholine to sphingomyelin ratio, we would like to have a high ratio. It declines with aging, but if we supplement with phosphatidylcholine, it will be increased in all 3 age groups, and the difference is most marked in the older rats, and that would correspond to a middle-aged or elderly human. So when we add to these heart cell reaggregates liposomal phosphatidylcholine, similar to what we're taking with lipophosphatidylcholine or Detox Max, the cholesterol to phospholipid ratio will fall, the phosphatidylcholine to sphingomyelin ratio will rise, CPK rises with age. It is a sign of cellular dysfunction, aging, a problem with the cell membrane, so the body has to compensate by making more of this enzyme because it's not working so well. It rises, and instead it falls with phosphatidylcholine. And I see this in my patients. When we're using phosphatidylcholine primarily like as an anti-aging therapy, I will see a reduction in your CPK levels. CPK is found in muscle and in heart. It is released into the circulation when these cells are damaged or strained or stressed. If you have a heart attack, your CPK level will rise. If you are traumatized, your muscles will leak out CPK. But just with aging and dysfunction, we will see this slight rise in your CPK, and we can blunt that with phosphatidylcholine. And my interpretation is we're improving cell membrane function, your biology is improving, thus you need to make less CPK to generate energy in your cells, and thus your serum CPK level will fall. Here, we're going to look at 5-day-old and 15-day-old rat heart myocyte, that's the muscle cells, fibroblast cells, those are the connective tissue cells, and the endothelial cells that line the vessel wall. So in the young cells, we have lots of phosphatidylcholine in the cell membrane, less sphygmomyelin, less cholesterol. We're going to have a fluid and elastic and functional cell membrane. As the cells age, we see a drop out of phosphatidylcholine, an increase in sphygmomyelin, an increase in cholesterol. That cell membrane will not be fluid and elastic. It will not be as functional. If we treat the 15-day-old cells with liposomal phosphatidylcholine, we will increase the representation of phosphatidylcholine similar to that of a 5-day-old cell. We will decrease sphygmomyelin and we will decrease cholesterol. Instead, if you treat the 15-day-old cells with liposomal sphygmomyelin, you will not see an increase in phosphatidylcholine. Instead, you see an expected increase in sphygmomyelin and some decrease in cholesterol because the sphygmomyelin is kicking out the cholesterol. But the sphygmomyelin is not desirable, and we would not expect that that cell membrane would function well. They use two measures of cell membrane function, resistance and diffusion, which I didn't quite understand, but you would like to have low resistance and high diffusion. This is the young cell membrane, the 5-day-old. Here we have the 15-day-old cells, the cell membrane. You can see resistance increases, diffusion decreases. There's cell membrane dysfunction. If you treat the 15-day-old cells with phosphatidylcholine, you have a more youthful appearance, less resistance, greater diffusion. Sphygmomyelin, of course, did not help. So flooding the cells with phosphatidylcholine increases representation of phosphatidylcholine, decreases representation of cholesterol and sphygmomyelin, improves cell membrane function. Enzymes run our physiology, and these enzymes are found in association with membranes, either the cell membrane that surrounds our cells or the membranes that surround the organelles, the functional centers within our cells. Cell membrane function is optimal in the young 5-day-old cells, and we see low levels of the various enzymes. In the older cells, phosphatidylcholine is dropping out, cholesterol and sphygmomyelin are rising. The enzymes don't work as well, so you see higher levels of the enzymes. If you treat the 15-day older cells with liposomal phosphatidylcholine, you improve cell membrane function and the enzyme levels fall. ATPase enzymes are utilized to do work within the cell, to split off a high-energy phosphate group from ATP to make ATP so the cells can do work. And you can see, like the other enzymes, they're not working so well in the older cells. You have higher levels of the ATPases. If you treat the older cells with phosphatidylcholine, they fall to useful levels. CPK is going to rise in the older cells, and it will fall in the older cells that are treated with phosphatidylcholine. And the levels actually fall below the levels of younger cells. So you're creating vitality within the aging cell and cell membrane by supplementing with phosphatidylcholine. You're increasing the representation of phosphatidylcholine, you're decreasing the representation of cholesterol and sphygmomyelin, better cell membrane function, better enzyme function. You see a reduction in CPK. Can phosphatidylcholine promote the viability of rat heart cell reaggregates. Here they took newborn rats, removed their hearts, diced them up, put them in tissue culture. The cells will reaggregate and begin to beat. And they will continue to beat as long as the cells are viable. Stated otherwise, as long as the cell membranes are intact and functional. The untreated cells will beat just fine for about 5 to 7 days, and then they begin to falter and they die as the cells become devitalized. If you add in liposomal phosphatidylcholine at day 5, the cells continue to beat because cellular viability has been maintained, because phosphatidylcholine provides antioxidant, anti-inflammatory effects, protects the cell membrane, the cells stay alive longer, they continue to beat. Curve C, instead of adding in phosphatidylcholine, you add in sphygmomyelin. That helps a little bit because sphygmomyelin is better than no phospholipid, but it's not nearly as effective as phosphatidylcholine. In curve D, you add in the phosphatidylcholine at day 5, you take it out at day 11, and then the cells begin to falter. If you add back the phosphatidylcholine, they come back online. So representation of phosphatidylcholine within the cell membrane preserves the viability of these cells. If the phosphatidylcholine drops out, the cells become devitalized. If you add it back in, cell vitality improves. These in vitro or test tube studies suggest to me that phosphatidylcholine supplementation would promote longevity. Let's look at the effect of intravenous phosphatidylcholine on longevity in elderly but healthy Sprague-Dawley rats. Sprague-Dawley rats typically die at 24 months of age. These rats have made it to 30 months. Obviously, they are healthier than the usual Sprague-Dawley rat, but they're not going to live forever. Let's see if phosphatidylcholine will promote longevity in these healthy but elderly rats. So you take the rats and you provide an IV infusion weekly for 2 weeks and every 2 months, either of phosphatidylcholine or saltwater saline as a control. The control rats they die earlier, 32 months, 34 months, one makes it to 40 months. All the rats that were treated with phosphatidylcholine lived longer. 3 of them lived up to 48 months. Treatment was initiated at advanced age. So this would be like treating a human in their 70s or 80s. Average age at death was extended by a third from 36 to 46 months, and they estimated this would be equivalent to 25 years of human life extension. That's something that I would like for myself, to live longer while maintaining youthful vitality. And speaking of aging rats, here we have my good friend and colleague, R.H. Poling. Now, Dr. Poling is 120 years old. He just takes really good care of himself. He takes an awful lot of phosphatidylcholine. There's a rumor that that Dr. Poling gave Dr. Rince the idea about, generating the Rince formula. So anyways, if you want to look like Dr. Poling when you're 120, I would suggest phosphatidylcholine supplementation. Now, I'm fibbing a little bit about Dr. Poling. Dr. Poling's not quite 120 years old, but he does look good for his age, and we want to keep Dr. Poling around for a while. So if you're a Dr. Poling patient, please remind the good doctor to keep taking his unsaturated phosphatidylcholine. Now let's examine the mitochondrial clock theory of aging. We're going to look at age-related hearing loss in elderly 20-month-old Harlan Fisher rats. Half of the rats receive their usual diet, Purina rat chow. The other group of rats receive the standard diet plus unsaturated phosphatidylcholine supplementation. Hearing loss at multiple frequencies was blunted over the ensuing 6 months. So normally, as these rats would age, they would lose their hearing. That was blunted with phosphatidylcholine supplementation. Mitochondrial membrane potentials. We want a high electrochemical gradient across the mitochondrial cell membrane. That means that energy generation with the mitochondria is intact, the membrane function is normal. On the controlled diet, we see a decrement, an aging-related decrement in the mitochondrial membrane potentials. In other words, mitochondrial function is deteriorating. If the mitochondrial function is deteriorating, we can't make energy. If we can't make energy, our cells cannot function and we will begin to age. The animals that received the standard diet plus phosphatidylcholine, there was no decrement in the mitochondrial membrane potential. Thus, mitochondrial function, which is key to health and longevity, was preserved with phosphatidylcholine. Age-related deletion in mitochondrial DNA was blunted. As we age and experience oxidative hits, our mitochondrial DNA is damaged and it drops out. As we lose mitochondrial DNA, vitality is lost. So phosphatidylcholine improved mitochondrial cell membrane function. It protected against loss of mitochondrial DNA. The mitochondrial function was maintained, and hearing loss was blunted. And other aspects of their physiology would also have been preserved had they looked. So in these cell culture studies, we've seen that exogenous phosphatidylcholine reverses the age-related cell membrane phospholipid change that would be otherwise expected. With aging, phosphatidylcholine drops out. It's replaced by cholesterol and sphingomyelin. We're going to have a stiff, dysfunctional cell membrane. We can reverse that and restore a youthful phospholipid composition of the cell membrane with exogenous phosphatidylcholine. Phosphatidylcholine supplementation restores enzyme levels towards their youthful levels. The age-related increase in osmotic fragility is reversed. Here you take cells and put them in a solution with either excessive or insufficient salt. This will create a gradient in the salt content between the cell and the surrounding fluid, and that will stress and damage the cell membrane, and the cell membrane will die. So, and with aging, as we lose phosphatidylcholine, tolerance to osmotic stress falters. But if you treat the animal with phosphatidylcholine and then remove the cells and expose them to osmotic stress, the resistance to osmotic stress damage is blunted, and all of a sudden the cells from an 18-month-old animal start acting like the cells of a 3-month-old animal. Tolerance to respiratory stress in 18-month-old elderly rats is improved. You put them in a chamber and you remove the oxygen. You create hypoxia. You'll see a gradual reduction in blood pressure to 0 followed by cardiac arrest. If instead you treat the animals with 3 IV treatments of phosphatidylcholine, their tolerance to hypoxia improves, blood pressure is maintained 50% longer versus controls, CPK release is blunted. So the cell membranes are not rupturing in response to hypoxia. We talked about age-related hearing loss in the elderly Harlan-Fisher rats, sexual competence in elderly 30-month-old male rats. So you take these older male rats, put them in a cage, and you put in a young girl rat. The old guy will get up, sniff around, and go take a nap. Not very interested. So then you treat the old rats with IV phosphatidylcholine, bring the young girl rats back. All of a sudden, you got a lot of baby rats. So sexual competence with aging appears to be enhanced with phosphatidylcholine. Another good reason to take phosphatidylcholine. We've covered a lot of ground, beginning with Jacobi's rinse and the rinse formula. We talked about how Natterman AG, a German pharmaceutical company, purified phosphatidylcholine. They would distill the soybean-derived phosphatidylcholine to come up with lipostabile, a phosphatidylcholine preparation enriched in linoleic acid. This material is now available in generic form, intravenously or orally, and we can admix EDTA, lipoic acid, magnesium into the microspheres of phosphatidylcholine, creating a oral delivery system for phosphatidylcholine and EDTA. How does phosphatidylcholine work? It improves enzyme function. Dr. Rince knew that if he didn't have the proper catalysts, his chemical plants would not be functional. He hypothesized that the enzymes that were governing his cardiovascular physiology did not have the proper raw materials, so he came up with the Rince formula, which is primarily unsaturated phosphatidylcholine. So his enzyme system was improved. Phosphatidylcholine will increase the activity of enzymes that clear lipids from the blood. Conversely, the enzymes that will pull lipids into the artery wall and cause formation of cholesterol oleate, cholesterol ester, are decreased. The enzymes that will break down cholesterol oleate into free cholesterol and then promote its reesterification with linoleic acid into the HDL particle to promote reverse cholesterol transport are increased. Cell membrane fluidity and function improves, as we've been discussing. Our arteries become more elastic, platelets are less sticky, blood viscosity falls, so blood is more like wine and less like ketchup. The ability of the blood to dissolve a clot, fibrinolytic activity improves, microvascular blood flow improves, homocysteine falls. As we've recently discussed, phosphatidylcholine has a powerful antioxidant and anti-inflammatory effect. Eicosanoid metabolism, the ability to convert essential fatty acids into beneficial prostaglandins, is enhanced. Signs and symptoms of vascular insufficiency will improve. In our patient with coronary disease, you'll experience less angina. You'll require fewer nitroglycerin tablets. Your treadmill performance will improve. Total treadmill time, time to ST depression, that's the time point at which the cells do not have enough oxygen. If you have peripheral vascular disease, calf cramping with ambulation, we call that claudication, will decrease. You'll be able to walk farther before symptoms develop. If we look at plaque volume, we're going to stabilize or regress plaque with a concomitant improvement in blood flow. Part 2 of our discussion covered the powerful antioxidant and anti-inflammatory effects of PPC. We showed that PPC will improve cell membrane function and deal with any methyl cycle dysfunction that may be present. If we have antioxidant, anti-inflammatory effects, if we repair the methyl cycle, if we improve cell membrane function, then we're going to provide protection to our cells and organs in response to any stress. We covered the benefits of PPC in reperfusion injury. We talked about how PPC is a benefit in upper and lower GI tract inflammation. We had the cardio-hepatology section showing that PPC is of value in liver disease. We touched on the role of PPC in neurologic health, cancer protection. We discussed TMAO as a potential downside of PPC, one that we can measure and neutralize, and we covered potential anti-aging benefits of PPC supplementation. How are we going to utilize PPC to obtain these physiologic benefits? If our target is an inflammatory condition involving the upper GI tract, of course, we're going to be utilizing PPC in an oral format. If our target is a disease state involving another organ system, or if we simply want to improve cell membrane function in general, we can use intravenous or oral PPC. Oral PPC is available in Europe as lipostimular and essential, in the United States over the counter as Foscol or Plaquex. I take 900 milligrams of Foscol 3 times a day. Intravenous PPC was discussed in detail in part 1 of this discussion that focused on the use of PPC in atherosclerotic vascular disease. Most of my patients with coronary disease who are receiving intravenous PPC do so within the format of a 90-minute slow infusion, where we administer increasing doses of PPC mixed in dextrose. Alternatively, we can utilize the IV slow push methodology. Here we take a syringe, fill it halfway full with PPC. We puncture your vein, pull back some blood, we agitate the syringe so the PPC will adhere to the cell membranes of red cells. This mixture is then slowly infused. By mixing the PPC with the red cells, it is felt to ensure a more even distribution of PPC throughout the body. If our focus is on a neurologic condition, we will utilize the lipid exchange format. Here, PPC administered via the slow push method, followed by intravenous glutathione and intravenous folinic acid. So the IV PPC will enter the brain, it will improve cell membrane function, and provide powerful antioxidant and anti-inflammatory effects. Some of the PPC will be metabolized to choline. Choline is the raw material that the brain uses to make the neurotransmitter acetylcholine, which is involved in memory, acquisition, and retention. Glutathione is an antioxidant. Folinic acid improves the methyl cycle. So when we're focusing on health challenges involving the brain, we will use the lipid exchange program. If a concomitant goal is heavy metal detoxification, we may use oral microencapsulated PPC and mixed with EDTA. If our focus is on cardiovascular disease, we can use the RINSE formula. And if we're dealing with active or extensive or potentially threatening cardiovascular disease, I will often recommend concomitant supplementation with lumbrokinase. So we have many methods available for the administration of PPC, and we match the method to the preferences of the patient and the health challenge that the individual patient bears. To learn more about PPC and other approaches that we utilize in integrative cardiology, please look at Reverse Heart Disease Now. You now know all that I know about polyenylphosphatidylcholine, PPC, but within the framework of integrative cardiology, there's much more science that we can discuss and many new therapies that we can offer you. Thus, on the heartfixer.com website, there are a number of DVD and audiovisual presentations available for your review. Some are old, some are new, and many more will be added in the future. I've learned a lot about phosphatidylcholine. I hope you've learned a lot as well. Where did I learn about this approach? The best source of knowledge is the Lipostabile monograph. This was put out by Rohn Pullenik Rohr, a German drug company who bought Natterman, which was the company that came out with Lipostabile. And this monograph references hundreds of articles. Most of the studies have been done in Russia or Germany. They've not been translated into English, but they're summarized in the Lipostabile monograph, and this was a great source of information. A basic science booklet, Phosphatidylcholine, Biochemical and Clinical Aspects of Essential Phospholipids, edited by H. Peters, is a great source of basic science on phosphatidylcholine. N-Essential is Lipostabile with a different name. They market Lipostabile to treat cardiovascular disease and N-Essential to treat liver disease. And this is a table of contents of the N-Essential monograph, just in case you're a hepatologist and you want to know how you can utilize PPC to treat your patients. The studies that I have cited in this presentation are presented on the following pages. We'll start with basic science, lipid management, platelet and microcirculatory function, neurology, clinical cardiovascular effects, the effects of PPC in animal models of experimental atherosclerosis, antioxidant and anti-inflammatory effects, homocysteine management, the benefits of PPC therapy in disease states involving the GI tract, the use of PPC in ischemia reperfusion injury, and protecting our organs from toxic insult. The section that I describe is cardio-hepatology, the use of PPC in dealing with diseases of the liver. And these are the references regarding TMAO and the studies discussing potential anti-aging effects of PPC supplementation. We're done. Our marathon session on the use of 1,2-dilinylphosphatidylcholine within the framework of integrative cardiology and health promotion is complete. I feel that you have completed your training. You're now experts and you deserve a Heineken. Of course, if you're my age or older and you want to feel like dynamite when you're 85 and 95, I would suggest rather than a Heineken, you turn to a Heinekol. I hope you got a lot out of this presentation as I got a lot out of preparing it. Thank you.